Okay, fine. Thank you. Hi, guys. So the countdown has started, and this is your moment to shine. The objective is obviously to narrow down to the correct answer of the questions that I'll be discussing with you. But I've divided the discussion into three parts. First would be a couple of tables, which are like, must know topics that you should be knowing. Then I'll obviously focus on certain buzzwords or the keywords, which would help you, get down to the right answer. And then obviously, like, just like we do clinical comparison, like when a patient comes, we draw a list of differential diagnosis. So in a similar spirit, what we'll be doing here is also doing that speculation part of why, like, a particular diagnosis would be apt or would be appropriate for a particular condition. सो आज खेलते हैं क्वेश्चन एंड आंसर वाला गेम। तो अभी तो टेबल्स तो डिस्कस करूंगा ही, बट बिफोर वी डू दैट लेट्स डू सम क्वेश्चंस आल्सो जो इनिसेट पैटर्न को रेप्लिकेट करते हैं। एंड देखते हैं अब आपने क्या क्या रिस्पॉन्सेज दिए हैं। आई ऑल्सो जस्ट चेक द ऑडियो द विजुअल वाला फीड, इफ एवरीथिंग इज गोइंग फाइन तो वी कैन लाइक गो हेड। हाँ जी बेटा, नॉलेज तो कभी वेस्ट नहीं जाती है, तो आप कोई भी एग्जाम की तैयारी करोगे तो आई थिंक इट्स इक्वली यूजफुल फॉर एनी काइंड ऑफ एन एग्जाम। And as far as the duration is concerned, uh, I'll try to keep it brief. I know that in an era where everything is instant gratification, everybody wants to, imbibe the information fast. But I assure you, it would not be like humongous kind of a data overload. It's gonna be doable, right? So let's get started, guys. The first thing on the agenda is to talk about this particular case. I have this patient diagnosed with a lung cancer with shortness of breath, and you know that oat cell cancer can very easily metastasize to the heart, so there can be a malignant pericardial effusion developing in the patient. Okay, I'm getting correct answers here. Also, a couple of people's names I have missed. So, let's get down to the real game instead of like, the greed meat and the greed part that we can do later. So the blood pressure is doing decent at the moment. That's why I did not say the word cardiac tamponade. It looks pretty fine. Malignant pericardial effusion. And then echocardiography shows a diastolic collapse of the ventricle of the atria. Now that's of concern. And because there's a diastolic collapse of atria, that means that this patient is having a low pressure cardiac tamponade. So therefore, when I read the first two lines of the MCQ, I thought it could be a lung cancer metastasizing to the heart, because this give me pulse, blood pressure, respiratory rate values, and then I thought maybe he'll give me some JVP findings as well. But he straight away gave a echocardiography finding, which is pretty ominous. It's a cause of concern. You see, what is the difference between low pressure cardiac tamponade and plain cardiac tamponade is that low pressure would be causing collapse of only the atria. So there would be something around about 30% decrease in the blood pressure value. So pulsus paradoxus may not be developing in this patient. But yeah, I mean, if there's fluid outside the heart, there is bound to be presence of electrical alternates. That is because the heart is dancing in a bag of fluid. Anytime like there's a cardiac tamponade, or even if I don't focus on the word low pressure, I just want to say that the person would still be having fluid outside the heart, so there is a fluctuation in the electrical axis, so it makes sense. And because the atria is collapsing, so the backflow would result in, like, all the venous return comes into the right side of the heart. So if the atria is going to be crushed, it's going to be squeezed, then there would be plethoric in inferior vena cava as well. I'm getting a D in the question, or option number 3 in the question, which I think a lot of guys are making a mistake, because if you say Kussmaul sign, sir, Kussmaul sign is not seen. I've emphasized that a lot of times, but I'll say that once again, because as you progress into cardiac tamponade, then it becomes a non-pulsatile elevated JVP. And because it is a non-pulsatile elevated JVP, Kussmaul sign will not be present. I'll call the first question, in case you answered it as option number 3, as a silly mistake, because Kussmaul sign to milta nahi na, guys. You see, distant breath sounds, I understand. Obviously, you were smart enough to pick up that distant heart sounds would be there, not distant breath sounds. But then Kussmaul sign is not going to be there. Kussmaul sign is a feature that is going to be seen in conditions where we say COPS restrict right heart. I'll just mention a mnemonic here just to get going for those of you who might be listening to me for the first time. Just a quick mnemonic here, and then I'll give you rationale also. COPS restrict right heart is a baseline question where COPS का काम ही कहीं का ना restriction करना. So COPS would be constrictive pericarditis. Restrict would be standing for restrictive cardiomyopathy, and then it's going to be right-sided congestive heart failure. And since you would be saying, sir, I want rationale for INI-CET, because INI-CET is not going to be solvable on the basis of some mnemonics, right? That's just an introduction part. What I want you to understand is that whenever you deal with cardiac tamponade, or whether it's low pressure or whether it's a cardiac tamponade that's in the process of development, you would be having is a development of elevated JVP, but it would be non-pulsatile. The only time in medical science where you get non-pulsatile elevated JVP, I want you guys to comment in the chat box. When do you get non-pulsatile elevated JVP apart from obviously the topic of cardiac tamponade? I mean, apart from this, where else in medicine have you read non-pulsatile elevated JVP? The correct answer to the first question is option number 1 only. Only option A and option B are gonna be correct. So yes, guys, where do you get non-pulsatile elevated JVP? Very good. Dhanush was the first one to comment for this one. Non-pulsatile elevated JVP. Remember, in whole of your medical science, every time the heart is involved, it's always gonna be pulsatile elevated JVP. Only 2 times you would be having is a non-pulsatile elevated JVP. One is superior vena cava thrombosis or superior vena cava obstruction that would be developing again due to a lung cancer. Usually most of the time would be a central lung cancer which will squeeze on the great veins. That's why non-pulsatile, because when it will squeeze on the veins, obviously the column will go up, but then the pulsations disappear because the transmission of the pressure of the heart, you see when the heart is contracting, relaxing, that's why we get A, C, V, X and Y waves. So superior vena cava thrombosis, the transmission of pulsation would not be happening. So 2 times, remember my words, where you get a presence of non-pulsatile elevated JVPs, cardiac tamponade and superior vena cava thrombosis. And the answer to the first question is option number 1. And I would suggest you to avoid the silly mistakes, and that is why I'm gonna just make you practice here. I mean, how do you identify cardiac tamponade? Then don't waste your time by going for pulsus paradoxus. Pulsus paradoxus can be seen in pregnancy also. Pulsus paradoxus can be seen in patients of asthma who are progressing towards status asthmaticus or for severe acute asthma as well. So a lot of students, they waste their time trying to search for pulsus paradoxus or like a description related to it. What I would suggest is that's just a prop. What you have to understand is that in patients who are having cardiac tamponade, the small sign is absent. That is one way of putting it. Or the other way of putting it was the way I was saying it. That would be a non-pulsatile elevated JVP. Great. And as far as the right hand side is concerned, obviously you get a paradoxical rise of JVP with inspiration. So small sign is going to be seen with respect to constrictive pericarditis. And what is small sign? It's a paradoxical rise of JVP with a deep inspiration. Once we sorted it, then some questions that you would be getting in the paper will again be having JVP waves also given. So it could be steep X and steep Y, both common things for both of them. Now what you will pick up is obviously the absent Y descent for cardiac tamponade. The reason is that the filling of blood in the heart will be big time compromised. And when I to go about the right side, I will say steep X and a steep Y descent. A lot of you get, disturbed by the word steep X. Don't get disturbed. Learn to filter the noise. There would always be some information that's gonna be putting stress on your brain. What is the steep X? Now for that you can go to the main videos, but at this point of time I would not suggest you to do that. I would suggest you to focus on what is the fundamental difference, that is an absent Y descent, and no need for any mnemonic. It is rational, sir. In any set, it's not the funny mnemonics that work. It is the impaired filling. Imagine the heart is being crushed from outside. That's why the word written is diastolic collapse of ventricles. If it's a full-blown cardiac tamponade, we say diastolic collapse of ventricles. If it's going to be a low pressure, then there's a diastolic collapse of the atria, because obviously atria is a low pressure chamber, so it will collapse relatively first. Now, suppose you say to me that, sir, in the end, my brain is just cooked, right? Like that Gen Z language, my brain is cooked, and how do I solve the question in a jiffy? Jiffy means in a second, right? Then blood pressure. I mean, if you get a question where the blood pressure begins to crash or there's a hemodynamic instability, then it's always going to be cardiac tamponade in a patient, and both of them would be having low voltage ECG because obviously there is fluid outside the heart. Well, what is the definition low voltage ECG? If the height of the R wave and the depth of the S wave is less than 5 mm in the limb leads, there is no need for subtraction. Whatever is the height of the R and the depth of the S waves, just count the number of chota baksa or the boxes. And if you don't do any subtraction, it's that addition. And then in the limb leads, if the value is less than this, then yeah, I wish Beck's triad was asked for these questions. I wish paper was so simple that they said Beck's triad. If this was given, we would not be having this discussion. Okay, so I really wish, at my time when I was a student, Beck's triad was the only thing we used to study and solve the question of cardiac tamponade. But if you go through the current generation of questions, I mean, show me one time Honestly, show me one time in last 5 years where they mentioned the word Bextride. I mean, if that was it, we will not be having this conversation. Okay, great. Next, moving on to the chest X-ray finding in these patients, that would be a slight difference because when I talk about cardiac tamponade, the cardiothoracic ratio would obviously be increased, and in constrictive pericarditis, because there's a calcification, the cardiothoracic ratio would be normal. And if it gives you a good in X-ray, that you might be able to see the calcification outside the heart, because constrictive pericarditis is anyway going to be like a sequelae that can be seen, and obviously that fancy words like money bag appearance and I mean, I wish though they mentioned those questions where money bag appearance, etc. was given. They usually don't do that. And as far as the management is concerned, the diagnosis would obviously be confirmed by doing an echocardiography, where the keyword in the question would be the investigation choice for distinguish between the two is echocardiography. If the question says the word diastolic collapse of the ventricles, that's classical terminology for the question of cardiac tamponade. If I change my data and I say square root wave sign, that's also a cardiac catheterization finding, but then the compliance of the ventricles would be affected as well. And if I say the word square root wave sign, that goes in favor of constrictive pericarditis. So those are like two differences that I just wanted to bring to your attention. And then obviously in low pressure cardiac tamponade, yep, only the atria are getting crushed. That is the reason why the blood pressure is low, but not so critically low now. But the person, this is an ominous sign. So very soon the fluid amount will increase further, and you don't need like 2 liters of fluid outside the heart. There's a limited space, no, 20 to 50 ml. So if it jumps up from 50 to, let me say, 80, then 100, then 150, that enough is sufficient to cause a collapse of the ventricle subsequently. Yep, a septal bounce that can come up, square root wave sign that can come up. And as far as the interventions that we'll be doing, that would be in the form of pericardial stripping. So for the first question, my only request to you guys is that the table that I've currently discussed before you, you just need to practice it by yourself. The PDF, this comes in the Telegram group subsequently. But as of now, this question should not have gone wrong, maybe overconfidence, but this happens when we sit in the examination hall, first question pops up, we are all a bundle of nerves. And because of that, maybe, the first time it happened that it went wrong, but let's do it for the second question. Okay, guys, so boys and girls, hold tight. The second question is right in front of you. This guy, this is an excised heart tissue from a guy who was suffering from prolonged fever, shortness of breath, exercise intolerance, and then a diastolic murmur, which is a good hint that is given in the question. And then is given a histopathological specimen, because most of the questions that come would be relatively integrated. So fairly straightforward, guys. You would be able to identify that the patient is having spindle cells present. No? The moment you see the spindle cells present, obviously, initially, you might think that there might be presence of Ashkoff nodules as well. But the moment you pick up these myxoid, a lot of connective tissues present. So I can say a lot of myxoid tissue is present at the moment at the bottom. Then there are spindle cells that are present. So that would mean that the person would be having a cardiac myxoma, and cardiac myxoma will contribute to blockage. So you can also comment in the chat box. Yeah, in fact, somebody has already done. Can you comment on the auscultatory finding in this condition, please? Apart from obviously a murmur that would be coming. The main auscultatory finding that would be coming up in a patient with atrial myxoma. The correct answer for this question is option number B. Yep, the auscultatory finding is a tumor plop sound. So most of the time he'll make it relatively easier for you by putting up a tumor plop sound, which is happening to be a diastolic sound. It's a low pitch heart sound, so it will always be heard with help of a bell. It's a low pitch sound, always heard with the help of a bell. And the classical presentation in this patient is going to be platypnea. That has been asked in the exam earlier, though in this question I did not mention regarding the platypnea component, considering the fact that you are anyway familiar with it. The rationale is physical obstruction of the lumen of the left atria, so the pulmonary edema of the patient would be fairly severe. And yeah, we read platypnea actually 2 times, though it's a huge list. Common causes that we read is, one is atrial myxoma, and second is gonna be hepatopulmonary syndrome. So for the management, it is associated with Carney's complex. That's another part from the pathology domain that they can put up in the question for you guys. And you guys can help me out quickly. A differential diagnosis of this patient. That is, okay, what is the most common tumor of the heart that originates from the heart valves? It's slightly changing the question. This is hepatopulmonary syndrome, perfectly on. I am changing my question. This is a tumor of the heart. Okay, agreed. my question is, instead of starting, like, which tumor would be originating from the heart valves? Yes. Yes, tumor from the heart valves, because atrial myxoma तो ऐसे present करेगा ना. Atrial myxoma will be a pedunculated tumor. It will be having a stalk. It will be jumping in the lumen of the. It will be like, moving up and down, plopping up and down in the lumen of the left atria. But yeah, papillary fibroelastoma, exactly. Somebody commented very rightly. If the tumor is originating from the heart valves, that's a differential diagnosis of it. That would be a papillary elastoma. Yes, fibroelastoma. No, somebody is commenting on rhabdomyoma also. Well, that rhabdomyoma thing would be only with respect to, rhabdomyoma is, चलो आप लोग ही बोलना, मैं आगे आगे बोलूंगा तो things go out, cat goes out of the bag. Which is the most common malignant tumor of the heart in adult population? What is the most common malignant tumor of the heart in adult population? Yeah, papillary fibroelastoma is settled. But a primary word hai. This question is sorted. Just mets are overall the common one. I asked primary malignant. Yes, 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 yes. Okay, so I'm just waiting for answers here. I am having only one correct answer in the chat as of now. If I say the word primary malignant tumor of the heart, बेटा myxoma तो benign होता है, and a lot of guys are focusing on the word rhabdomyoma, which is for children ना, तभी तो I just stopped for a while. Yeah, there are 2-3 people, Jipanjali, Dr. Bella, they have been right. Primary malignant tumor in adult population is angiosarcoma. So don't make mistakes, guys. When it comes to primary malignant tumor of the heart in adult population, it is the angiosarcoma. And only when it comes to children that the answer would be given as rhabdomyoma. Rhabdomyoma, I emphasize once again, would be associated most of the time with tuberous sclerosis. So there he will give you that ash leaf macules and other manifestations that we study, like a Sjagren's patch, angiomyolipoma involving the kidney. Rhabdomyoma, that is, rhabdomyoma is a tumor that would be seen with respect to children. And then from the histopathological perspective, the slides are pretty clear. One is going to be like, this one, which you can see. And the second one is the spider cells that you can pick up. That spider cells is obviously for the rhabdomyoma part. So that you could obviously identify very well. And most of the time, the tumor causes physical obstruction. So it can cause even vegetations. It can cause, there could be like tumor embolization. I mean, why do we get fever in this case? The reason for fever is tumor embolization. The tumor cells are embolizing because it would be flopping up and down due to circulation. So tumor embolization explains the development of fever. Though infective endocarditis was also there, but for infective endocarditis, there's going to be like risk factors that would be present. Risk factors like, prosthetic heart valve or IV drug usage, some kind of a pacemaker in place, cardiac implantable electronic devices that would be present. So we sorted for the second one, and now FMG wala, I think it is 10th and 11th, na, the RRR wala. Okay, so answer to 2 is option number B. Then we have a quick look at couple of line diagrams for the types of pulses. These line diagrams are again, pretty frequently being asked. So, and this will help us revise certain cardiac conditions also. So, this is the normal pulse pressure tracing. Can you comment on option number B, please? Option number B is a slow rising pulse. It's like a slow rising pulse, because it is a slow rising pulse with a delayed peak. So, in those circumstances, I will be calling it an anacrotic pulse. So, this gives me an opportunity to make you revise the ABCD of pulse. This is a slow rising pulse, also called as pulsus parvus et tardus. And yep, the slow rise pulse would be that of valvular aortic stenosis, which is well known by carotid thrill and also presence of a ejection systolic murmur, where the intensity of the murmur will increase and then gradually will decrease. So they can just make you, like they can give a pulse and say for the corresponding condition, what is the murmur that would be heard? Well, it's a crescendo, decrescendo murmur. If you plan to draw this, then the intensity will be max in the middle of the systole and then will tend to go down. Then you can see pulses which are gonna be having 2 speed breakers. Instead of saying percussion wave, tidal wave, I'll say like this. Let me say this is speed breaker 1 in systole, this is speed breaker 2 in systole, and this is also speed breaker 1 and speed breaker 2 in the systole. But you can see the height of the 2 speed breakers is different. So if they give you specifically, if they specifically give you these two speed breakers, where the size is gonna be perfectly okay, where the size is gonna be, almost equal. For the second one, please. Yep. For the second one. For C, I'm waiting for option number C at the moment. Okay. You see, there have been questions related to this. The side of the speed breaker would be different. Yes, very good. This would be for valvular aortic regurgitation. This would be a collapsing pulse that is present. So Bispherians word is okay, but like the question would be primarily from the perspective of what is the valvular lesion that is associated. So if they give you the speed breaker 1 and speed breaker 2 of equal height, then you will say that this is going to be valvular aortic regurgitation, when the pulse will tend to collapse. And if he's going to be kind on me, he might even mention the word pistol shot sounds on femoral evaluation of the patient. That is one. And another feature that can be given is like Quincke sign, dancing carotids. In place of valvular aortic stenosis, it is carotid thrill, and here it is dancing carotids that would be given in the question. And along with that, it would be an early diastolic murmur. Instead of drawing it, I'm just highlighting the terminology here. That would be EDM, that is early diastolic murmur. So the size of the two peaks is almost equal. But if they give you a situation when there's going to be two like speed breakers in the phase of systole, but the size of both of them is not equal, then this goes in favor of hypertrophic cardiomyopathy. Now, for this hypertrophic cardiomyopathy, the technical word is that this would be a subvalvular aortic stenosis. This is a subvalvular aortic stenosis in a patient. So the question would still be which heart valve is involved, but everything else with the dynamics will change now. Earlier it was aortic regurgitation. Now I'm saying the word subvalvular aortic stenosis. So here the correlation would be that the murmur that is present would be ejection systolic murmur. And the highlight of this murmur is that this murmur will increase with Valsalva. You're all aware of the fact that traditionally all murmurs decrease with Valsalva standing a mile, right? No, because when you stand, the venous return to the heart will become lesser. But the murmur that tends to behave ulta of the normal murmurs, in a sense that the intensity tends to increase, that's going to be primarily answered it as Valsalva, that is Valsalva standing mile nitrate. The ejection systolic murmur in this particular case would tend to increase. Yeah, there are two exceptions, hypertrophic cardiomyopathy and mitral valve burlesque, but focusing on this part only. And I'll show you a specimen of hypertrophic cardiomyopathy that they showed in last time's paper. Pretty straightforward and easy to, very workable data. And then I'm gonna show you a pulse where like the two speed breakers are in different phases. Like, one speed breaker is in systole part and the second speed breaker is in the diastole part. So you can notice this is systole, this is diastole, and there are two different speed breakers that are being highlighted. Or in fact, like you can see that the dichrotic notch also looks accentuated. That's how I can put it. The dichrotic notch looks accentuated. So this kind of pulse can be seen even in patients of septic shock. But since we are restricting ourselves to the cardiac perspective, so dichrotic pulse is what I'm talking about. From the cardiac perspective, it would be seen in an enlarged globular heart. That enlarged globular heart would be a feature of dilated cardiomyopathy. So yeah, low cardiac output, septic shock, those are like very characteristic terminologies that I mentioned. But then, yep. At the moment, what I've highlighted are the various different types of pulse waveforms that you need to remember. That would be especially the ones where the size of the speed breakers in the phase of systole are unequal. The answer changes dramatically, and that is why like a quick practice of the same has been done at this particular point of time. So we sorted for the second one all at this moment as far as the questions are sorted. Now we move on to the topic of heart failure and we have a hypertensive patient who comes with shortness of breath. His HbA1c is 6%. In India, 6% is like, okay. Anyway, you have to tell me, why do Indians have a relatively higher HbA1c? Any reason for false elevation of HbA1c? Meanwhile, you can focus on the question also, like there's an evidence of LV hypertrophy. Hypertensive patient, hypertrophy makes sense. Diastolic malfunction also makes sense. And ejection fraction is 40%. So that is a cause of concern in the patient. Yep, Indians have iron deficiency anemia. Iron deficiency anemia tends to cause a false elevation in the value of HbA1c. In the ulta MCQ of this was hemolytic anemia. Like if I talk about thalassemia, the hemolytic anemia like thalassemia, that can cause a false decrease in the value of HbA1c. So those are some of the confounding factors that we need to remember. Famines, okay. So false elevation. And then he's saying which of the following drugs will worsen mortality in this patient. So yes, guys, quick answers for this one. Yeah, false decrease would be hemolytic anemia. I'm waiting for your answers there. You have to answer as 1, 2, 3, 4 basically, for this particular case. Yeah. Yep. Yeah, beta blockers are given in chronic heart failure. Na? They're not given in the acute variety. So the person is having a heart failure, but hmm, 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 hmm. Okay, so most of the time either it is going between two. See, SGLT2 inhibitors will obviously be used nowadays, and considering that he's having HbA1c also high, maybe a pre-diabetic. So, like I'm not saying that SGLT2 inhibitor will take care of the diabetes component, but it will help in salt loss, so it will be beneficial. And then the second drug that would be beneficial for this patient is ARNI also. So these drugs would obviously be beneficial. But considering ejection fraction is 40%, and then if I'm using metazolone in the patient, it's not gonna be beneficial. And then metoprolol, well, I can say that like with a low ejection fraction, I'll be a little wary to use it. So C and D are like the ones which would not be really beneficial in this particular case. So A and B are the ones which are the correct ones, and what is not going to be useful is C and D. So the correct answer to question number 3 is option number 4. And then as far as heart failure with preserved ejection fraction is concerned, again, one of the main drugs that have been shown to reduce mortality is ARNI and SGLT2 inhibitors. The correct answer, yeah, C and D are the perfect ones which are picked up here. And let's beta blockers, because ejection fraction is like, I'll not say worsen mortality. I'll say like this: beta blockers gonna slow down the heart rate, right? They would conserve oxygen, but considering a diastolic malfunction, it would really not be beneficial for the patient. Yeah, yeah, yeah. Beta blockers, I agree to you. They are AMPA and DAPA. The GFR is up to 20. Anything less than 20 will be using DPP4 inhibitors in a patient. Yeah, I agree that four pillars that I mentioned, where there I mentioned regarding the role of metoprolol in the person patient as well. But most of the time it is like in those patients where, like considering the combinations which are given, I will say that there was no single best answer that could be selected. So that's why some bias is present there. Okay, so agreed. Like some of you who have raised is a genuine query, but at the same time, like considering the options will anyway rule out diuretics and then beta blockers considering low ejection fraction in the patient. Okay, moving to the next part, that is acute pulmonary edema due to hypertensive crisis. Considering hypertensive crisis, can I have quick answers for what would be the best drug that would help in control of high blood pressure in the patient? And then talking about cardiogenic shock and heart failure with preserved ejection fraction. For preserved ejection fraction, anyway, it's like the same thing that I said. It's ARNI that would be used. Absolutely. I just wanted to bring to your attention that if it is normotensive patient and there's a pulmonary edema, then we give diuretics. But in a hypertensive patient, it is nitroprusside. I think you guys just want to modify a bit. Yep. It is nitroglycerin. It is NTG. The mnemonic we have discussed already, now that is LMNOP, Lasix, morphine, nitrates, oxygen, and positioning. But for hypertensive crisis in a pulmonary edema, nitroglycerin would be helping to decrease. Cardiac emergencies are always asked, guys, and if it's if it's normotensive, you answer Lasix and furosemide, understandable. But here it is nitroglycerin, has been discussed multiple times. In CNS, it is nicardipine and labetalol, and from the cardiovascular perspective, it is nitroglycerin, not sodium nitroprusside. Nitroprusside causes a very fast fall in the value of blood pressure. You tend to like decrease the cerebral perfusion, and here I don't want to lower cerebral perfusion. I want to treat the pulmonary edema. No? See, if I say heart failure, pulmonary edema, that implies that there has to be some drug that will decrease the preload. If you decrease the venous return to the right side of the heart, the pulmonary edema component is bound to decrease in these patients. So, yep. As far as heart failure with preserved ejection fraction is concerned, like I'll say only two drugs have been shown to have some kind of benefit. One is SGLT2 inhibitor, the salt loss part, and second is the ARNI. Nothing beyond that would be very sufficiently, like at least from the evidence-based medicine perspective, that's what the book says there. Yeah, sodium nitroprusside only in aortic dissection. And then for cardiogenic shock, you guys can quickly hit the comment button for the same also. I mean, if I give between the three, norepinephrine versus norepinephrine, then you want me to give options. Okay, dopamine, dobutamine. So can I have answers, please? Yeah. Yes, it would be Okay, I'm getting dobutamine for the patient. So for cardiogenic shock in a patient, dobutamine is usually used when the systolic blood pressure is more than 100. Considering that it will have a alpha blocking action, it would not be a very, very good idea. And dopamine तो आजकल use नहीं करते ना. I think you are aware that the latest edition of Harrison has mentioned that also the dopamine causes arrhythmias. It is a pro-arrhythmogenic drug, so it is not recommended. So NORAD is one of the commonest ones that we are using. And what now norepinephrine will do is that it will increase the diastolic blood pressure. By increasing the diastolic BP, it will increase the coronary blood flow in the patient also. And if you increase the coronary blood flow, then the hypoxia in the heart will become relatively less in the patient. So refractory shock in a patient, भाई ऐसे नहीं होता है ना, ऐसे रट्टा ये कोई 10वीं 12वीं की तो है नहीं है कि भाई कितने परसेंट सिलेक्शन हो जाएगा. ओके नहीं यार नहीं, वो दैट्स एन ओल्ड डेटा. डोपामिन फॉर ओलिग्यूरिया दैट इज ऐसा नहीं है. अभी उसने बोला डोपामिन से फायदा ही नहीं है. डोपामिन इज गोना बी प्रो एरिथमोजेनिक, तो वो ओल्ड कॉन्सेप्ट था कि ओलिग्यूरिया. मैं तो बोल रहा हूँ ना, कार्डियोजेनिक शॉक का मतलब ही क्या होता है. कार्डियोजेनिक शॉक का मतलब ये होता है कि देर इज अ रीनल फेलियर अकरिंग इन अ पर्सन, देर इज अ एक्यूट किडनी इंजरी. आई मीन कार्डियोजेनिक शॉक का बोलेंगे व्हेन देर इज अ हार्ट फेलियर. And along with that, there is a acute kidney injury also developing in a person. That is when we see now that the person is in pump failure or cardiogenic shock. So dopamine is not gonna be working in these patients. Dobutamine works with beta 1. डोबूटामिन बीटा 1 को स्टिमुलेट करता है, वो तो ठीक है, हार्ट रेट को बढ़ाता है ना, बट अल्फा को ब्लॉक कर रहा है. सो इट वुड नॉट बी यूजफुल फॉर दोज पेशेंट्स विद द सिस्टोलिक बीपी इज लेस देन 100. सो नोरैड इज व्हाट इज द कॉमन थिंग दैट वुड बी यूज्ड इन द पेशेंट. And then is heart failure with preserved ejection fraction, that is SGLT2 inhibitor. So just a quick recap of certain important drugs. Full form of LMNOP are not written. It is Lasix, morphine, nitrates, oxygen, and positioning. Let's look at the next question. We have this man who came with chest pain for 4 hours. Okay, 4 options. And he's having this pain radiating to the left shoulder with a lot of sweating present. There's a tachycardia. The blood pressure of the guy is particularly low. And हाँ, तो फिनोल्डोपाम की बात अलग हो रही है ना यार. वी आर नॉट, अभी हमने डोपामिन की बात करी ना, तो डोपामिन तो नहीं दे रहे ना, फिनोल्डोपाम अलग बात हो जाती है. यप. Now coming to like the ECG findings here, this was in fact last time's INI-CET, and if you check out lead number V2, V3 and V4, there's a ST depression with an upright T wave present. If I zoom it further, you can see the ST depression which is present here. Also you can see the upright T wave also present. So this is like V2, V3, V4, all of them are showing the same thing. V2 also, V3 also, I'll just mark it here before you. Again, a upright T wave coming up. And even in lead number V4, so 1, this is a posterior wall myocardial infarction, suspected posterior wall MI versus non-ST elevation MI of the anterior wall. And what I need to do is then do V7, V8, V9 to be 100% sure about the diagnosis. So at this moment, like the question says, blood pressure is fairly low. So what will we be doing? He will say like, what is the next best intervention for management of this patient? So okay, so I can pick up IV fluids being given to this patient. क्या routinely MI में IV fluids देते हैं? Inferior wall MI की बात अलग है, बट इफ आई से posterior wall MI, क्या MI में IV fluid देते हैं? सर अगर किसी को MI की वजह से पल्मरी एडीमा हो रहा है, मोस्ट ऑफ द टाइम तो MI में पल्मरी एडीमा होगा ना, अनलेस एंड अनटिल स्पेसिफिकली मेंशन इट इज अ राइट वेंट्रिकुलर फेलियर, उसमें तो पल्मरी एडीमा होता नहीं है. बट रूटीनली तो मायोकार्डियल इन्फार्क्शन विल ऑलवेज बी हैविंग अ पल्मरी एडीमा प्रेजेंट. सो पल्मरी एडीमा में क्या फ्लूइड देंगे क्या, मतलब बंदा खत्म हो जाएगा सर. ये कोई हाइपोवोलेमिक शॉक थोड़ी ना. This is not a case of any hypovolemic shock that I will be giving a fluid bolus in a patient. The only time you give fluids is the inferior wall MI. This is not a case of inferior wall myocardial infarction. So in those circumstances, fluids to देंगे नहीं. So what is the main treatment of this patient? You have to do, sir, treat the MI. And what is the treatment of myocardial infarction? If I'm getting a ST depression in V2, V3, V4, that means there would be ST elevation present in रेसिप्रोकल चेंजेस होंगे ना. अगर मैं इसमें स्पेशल लीड्स लगा तो मैंने अपना टेक्नीशियन को बोला कि भैया जरा इसको V7, V8, V9 लगाना. द गाय इज हैविंग अ ST depression in V2, V3, V4. There would be a ST elevation present in V7, V8, V9. So the guy is having a ST elevation of the posterior wall. So how do I manage the patient? Send the patient for a PCI, that is a percutaneous coronary intervention. And if you open up the blocked coronary artery, then the hypoxia will go away, the hypoxia of the heart will go away, the cardiac contractility will automatically improve. Yeah, close option. If you said I will be worried between A versus D, I still understand. Intra-aortic balloon pump is used for management of patients having refractory hypotension. Like if somebody is in cardiogenic shock and the NORAD is not working, then what do I do? I can use intra-aortic balloon counterpulsation as a strategy to at least improve the coronary blood flow. But between the two, will that also treat the patient? No, because that is just a time pass maneuver that will improve the coronary blood flow. How do you actually increase the coronary blood flow? That is how to rule out C. Thrombolysis though is like a backup, na? Only if the question mentions specifically cath lab facility is not available. For option number C, if he says cath lab facility not available, only then you will say that okay, and the transport time to PCI equipped hospital will be more than 120 minutes, that we will do thrombolysis in the patient. So between A versus D, if A versus D to be considered, then the answer would be given as percutaneous coronary intervention, the PCI part, and that will take care of the myocardial hypoxia component in the patient. Yeah, why not intra-aortic balloon pump? That's a good answer. It is like chicken came before the egg or egg came before the chicken, like that. Let's try to solve it from science perspective. If, right, from science perspective, did MI result in hypotension or hypotension resulted in MI? Right? Normal thought process: chicken before egg before the chicken. No solution. But for our medical science, evidence-based medicine, MI is the cause of hypotension. So if you treat MI, the hypotension will go away. Suppose you're treating only hypotension, will you be able to? There was a head-on trial, comparing the two. Like they allocated, like everything we do is a randomized control trial. It's a peer-reviewed RCT that we did. So some patients were allocated for PCI with this same presentation of MI with hypotension, and couple of patients were allocated to IABP. Then they compared the comparison, and what they found was that when you're giving IABP, you are wasting time because you have not taken care of the coronary artery occlusion. So more necrosis in the heart is occurring. So tell, how long will you be able to sustain life with the help of intra-aortic balloon pump? So we have to go aggressive. We have to go ballistic and open up the blockage in the coronary artery. So as of now in these patients, it is settled. Earlier there was a dilemma. Some cardiologists used to say IABP is the best management. Some cardiologists used to say PCI is the best management, and the textbook also never used to say anything. But the current edition of textbook categorically mentions clinical trial done and shows, because we do a RCT, after that we do a meta-analysis, and it has been documented that PCI is successful. So I think at this moment I've given justification for why intra-aortic balloon pump is not the answer. And now subsequently, like वो permanent solution नहीं है ना. Thrombolysis is contraindicated in which situations? So thrombolysis would not be done in patients of non-ST elevation myocardial infarction. It would also be contraindicated if the BP of the patient is substantially elevated, usually in the excess of 185 by 110. And then I can say if a person is having bleeding tendency, bleeding diathesis, then again, like the INR of the patient, if it is substantially elevated, if I do thrombolysis, it can be rather a disaster happening in the patient. Unstable angina and non-ST elevation MI are standard contraindications, hypertension, bleeding diathesis, to say a few. Then is window period for thrombolysis in ST elevation MI. Can I have quick answers at the moment? Dr. Cricket. Okay. Chalo, badhiya. Good name. Ram Ram. No, we don't give fluids, doctor. We don't give fluids in myocardial infarction, because if we give that will worsen the pulmonary edema component. Only in infarable MI we give fluids. That's where the pulmonary edema is not there. Yep. I think everybody stroke से तो mix मत करो भाई. विंडो पीरियड फॉर थ्रोम्बो, अब यार तुम पता स्ट्रोक के साथ मिक्स कर रहे हो. विंडो पीरियड फॉर थ्रोम्बोलाइसिस एंड एसटी एलिवेशन एमआई इज अ ह्यूज 12 आवर्स. अगर किसी को सुबह 8 बजे एमआई हुआ है, अगर किसी पेशेंट को सुबह 8 बजे एमआई हुआ है, एंड ही कम्स टू योर हॉस्पिटल अप टिल 8 PM, you can do thrombolysis. Suppose the patient came at, let me say, 7. Suppose the patient came at 7 PM. So we have to start thrombolysis obviously as early as possible, preferably within 30 minutes. So that is what you are trying to say. The point for myocardial infarction is, no, that is totally separate. अब देखो मिक्स अप कर रहे हो सारी चीजों को. फर्स्ट मेडिकल कॉन्टैक्ट टू नीडल टाइम, इफ द पीसीआई सेंटर इज मोर देन 120 मिनट्स अवे. इसको चाहे ना भी याद रखो कि भाई पेशेंट को अब लेकर आए हो ऐसी जगह पे, मान लो लाइक आई एम अवे फ्रॉम मानेसर गोइंग टुवर्ड्स राजस्थान, गोइंग टुवर्ड्स हरियाणा, एट अ साइट वेयर मे बी PCI facility is not available. So ideally, though, we should refer to a PCI-equipped hospital if it is less than 2 hour transit time. But at a smaller place where the cath lab facility is not available, I will first say to the relative कि आप इसको बड़े अस्पताल में ले जाओ. वो कहते हैं सर कितना टाइम लगेगा, तो वो एम्बुलेंस में गूगल मैप पे तो आजकल कैलकुलेट कर ही सकते हैं ना भाई, हर हर गाड़ी में आजकल तो मैप वैप लगा होता है. तो आपने देखा कि भाई ट्रांजिट टाइम ज़्यादा लगने वाला है, तो दैट इज़ व्हेन वी विल डू थ्रोम्बोलाइसिस इन अ पेशेंट. सो थ्रोम्बोलाइसिस के लिए जो फर्स्ट मेडिकल कॉन्टैक्ट टू नीडल टाइम मतलब 30 मिनट्स वाला डेटा है, दिस इज हाउ इट इज. It is not to be mixed up in the window period in the patient. And then is obviously that first medical contact. The second aspect is first medical contact to balloon time. कि वो आए ही कैथ लैब वाले प्लेस में, लाइक ही केम टू अ कैथ लैब हॉस्पिटल, देन विद इन हाउ मेनी मिनट्स शुड वी बी doing a balloon angioplasty and putting up the stent in the patient, that is when it would be 90 minutes. So I wrote them in two separate terms there. Yeah, exactly. This 30 minutes is unofficially called as D2B, door to balloon time. And this is what is D2N, door to needle time. And this is what is called as door to balloon time. So one, I wanted to bring to your attention that D2B and D2N terms are not used. Now the word uses FMC, first medical contact to needle, first medical contact to balloon time. Earlier the terms used for door to balloon and door to needle time. Window period is very simple, sir. 12 घंटे for ST elevation MI, and for myocard for stroke it is 4.5 hours only. It is extended up to 9 hours. That is okay. That if we say specifically stroke के case में कि भी extended window period in select cases is up to how much duration, and if you say that it is extended up to 4.5 hour 2026 subject, understandably. But for acute ischemic stroke, the traditional would be हम देर से क्यों लाएंगे भाई? We would like to treat the patient as soon as possible. So in a patient of acute ischemic stroke, whether it is a large vessel obstruction, whether it's a small vessel obstruction present, and there are symptoms present in a patient, we should try to treat the patient within 4.5 hours in acute ischemic stroke. Only if he says the word that update 2020-26 says that instead of like 6 hours, now it is extended up to 9 hours. So that is just for select cases based on CT perfusion studies that we'll be deciding. Otherwise, only if he specifies this word, that update word comes up, that you would be considering this. Otherwise, absolutely no reasons. I think on the basis of the information that I have provided as of now, this should not cause any heartburn while attempting the questions at the moment. Yep. Divyash Shresht, you have a very good point there. Yep. Okay, so at the moment, I have just mentioned some core important issues, and I think most guys were able to get the questions answered right, though initially that error came up. We don't give fluids in a person of MI considering the pulmonary edema component. So we settled for fourth. The answer is option number A. We take up one more case. This chap is presented with shortness of breath and ankle edema, and he has been hospitalized for previous cardiovascular complaints also. Now, the guy died, and then is given post-mortem findings in the patient. Like he has mentioned, some gross findings, some slide manifestations are there, and your job is to identify like what can be the cause here. Okay, so I'm getting a lot of answers here. Let me just post-mortem shows interventricular septal thinning with dyskinetic left ventricle in a patient. तो यार ए कैसे हो जाएगा? अब यहाँ पे खुद ही लिखा dyskinetic left ventricle. It is not pushing blood properly, and there's a septal thinning present in arrhythmogenic right ventricular dysplasia. Those of you are saying option number A. The question should mention, and the slide में भी आपको दिखाई देना चाहिए that there is fat. So fat कहीं दिख रहा है? मुझे तो नहीं fat दिख रहा. Fat तो बिल्कुल खाली खाली जगह हो जाएगी ना. So it is like a पूरे round circles होते हैं. And another thing is there should also be fibrosis present. So that could be like, that he might give you a special stain like Mason trichome for the fibrosis component, which should be ideally present, not a standard hemotoxylin eosin. So fibrofatty deposition in the right ventricle. If I say that it is fibrofatty deposition which is present just below the right ventricular epicardium, below right ventricular epicardium, only then you will say that the answer to this question can be A. तो वो तो कहीं से फिट ही नहीं बैठ रहा है, तो arrhythmogenic right ventricular dysplasia तो है नहीं. A lot of people said restrictive cardiomyopathy in a patient. तो यार restrictive cardiomyopathy में तो फिर fibrosis again present होता है, and the usual cause for that is amyloidosis. And amyloid will be looking like dark pink. Amyloid would be looking dark pink on a slide. आप मुझे खुद बताओ restrictive cardiomyopathy में क्या अगर आप रिस्ट्रिक्टिव भी बोल रहे हो तो will restrictive cardiomyopathy result in a dyskinetic left ventricle with thinning of the muscle? With the thinning of the muscle, yeah, amyloid is dark pink. With thinning of the muscle, no, it's a normal thickness of the heart. Our hypertrophic cardiomyopathy presents between 20 to 40 years of age. It usually presents as like sudden cardiac death in a patient. ये तो बार बार हॉस्पिटल में आ रहा है, बार बार हॉस्पिटल में आ रहा है फॉर कार्डियोवास्कुलर कंप्लेंट्स. यार दिस इज अ पेशेंट ऑफ dilated ischemic cardiomyopathy. You see, the guy might have been having ischemic heart disease. That is why he wrote na hospitalized for multiple cardiovascular complaints previously. And ischemic cardiomyopathy अगर वो coronary artery bypass grafting नहीं करवाएगा, or he will not undergo any percutaneous coronary intervention stenting, then the ischemia will cause damage in the heart. So the correct answer, yeah, there is a interventricular septal thinning with dyskinetic left ventricle. That is a feature that is seen with ischemic cardiomyopathy. नहीं जी, यहाँ पे कहीं पे निंजा हार्ट नहीं होता. निंजा हार्ट कार्डियोमायोपैथी तो जेनेटिक होती है और बहुत रेयर होती है. So this is a ischemic cardiomyopathy that we're talking at the moment, where you can notice that the muscles are damaged. There is like fragmentation of nuclei that are present. So on some part you can see some orderly, like अगर मैं यहाँ पे स्टार मार्क लगाऊँ तो I can see some orderly arrangement of the myocytes. But उसके अलावा तो सारा disordered atrophied segments हैं, and there are some that are gonna be trying to do a compensation. So the answer for this particular question is option number C. It's a ischemic cardiomyopathy that would be present. If you missed it out, then for those who said restrictive, I can show for restrictive cardiomyopathy, there is no reason why you can ever in your life, ever mistake this again. Because if we will speak about restrictive cardiomyopathy, there would be jumbo size atria. The atria will be bigger than the size of the ventricle. Na? Normally, तो ventricles का जो size होता है, that is bigger than that of the atria because there is a fibrosis. This is stiffness in the wall of the heart. So the heart is working against the atria working against a resistance. That white is like the fibrosis part that is coming in. So suppose I said to you that there is like a ischemic, suppose I said that there is jumbo size atria, there's a disparity between the size of the atria and the ventricles. And then I said eosinophilic material which is present between the myocytes. It makes sense, restrictive cardiomyopathy, but no. Banana shaped cavity, okay, banana shaped cavity also I will show you. At this moment, there are a couple of more slides. Like some people had said ARVD. So I want to bring to your attention that ARVD slide will always be having fat, right? Fibrosis part, you need Mason trichome for it, but the fat part will be having lot of empty spaces that are present. So that fibropathy replacement that is present. The second one is unmistakable. That is the helter-skelter appearance that is seen with hypertrophic cardiomyopathy. The word that we use for that is called as myocardial disarray. The word is myocardial disarray. And then is the third one in which there is presence of hypertrophied myocytes. Like you can see a petit, I would say disorganized myocytes present, but some of them are relatively hypertrophied. The point that I've highlighted earlier and I want to bring to your attention at this moment is that hypertrophied myocytes, and then there are some which are atrophied, are a feature that is seen with respect to, yes, can I have the answer to the last one, please? The last slide that I just showed you, where you can see that most of even the nucleus inside the myocytes is all fragmented. I mean, it's not even visible. So hypertrophied myocytes are seen in, yep. That's a compensatory change that would be seen with respect to dilated cardiomyopathy. So most of the time they will give us some kind of a question with respect to the cardiac chambers where information would be given. And if the information given is like this, that I have currently highlighted, thinning of the interventricular septum, dyskinetic left ventricle, then you have to think as like ischemia being the primary cause, because in India it is such a common illness. So we are sorted for the fifth question for today. Let's go to the sixth one. This I know you will grab onto the opportunity because this is last time's INI-CET question, a straightforward repeat where you can see the banana shaped cavity. So this obviously, like, you can straight away say that, okay, this is motor heart, this is the thickened heart which is present. Can you quickly comment with respect to the answer in this patient? What is the plausible cause in this patient and like what is to be done in the chat? Yeah, it is between B versus D only, right? But like, what is the cause, right? The word is not arrhythmias. If I say cardiac arrest is due to arrhythmia, that is not technically an appropriate statement. The appropriate cause of death is like, there's a direct cause and there's an indirect cause. So the direct cause is hypertrophic cardiomyopathy. And then what is the advice to the family was also asked, na? So we would like to screen the family members. We would like to do at least a PCR, a gene sequencing for MYH7 gene, which would be sitting on chromosome number NYH7 gene, that would be sitting on chromosome number 14. So we need to screen the family members also, no? And if any family member is symptomatic or there is presence of hypertrophy more than 30 millimeter of the left ventricle free wall, then we will advise a implantable cardioverter defibrillator. So option number D is a indirect cause of why the patient is dying, but actual cause is that there's a motor heart that is consuming more oxygen, and because other family members are also vulnerable. And plus another point against D is the word heart block also. I mean, there's no heart block that is happening. Arrhythmias, I understand, it's a tachyarrhythmias. It is not a bradyarrhythmias that is present in this patient. So that is why we need to do gene sequencing, PCR, and then identify that there is a problem in this patient. In fact, the legend, Dr. Braunwald, who worked on hypertrophic cardiomyopathy, just died last week at 93 years of age. I mean, he's a legend of cardiology. If you've seen that book, Braunwald Cardio, it's a beautifully done book by him. And like he was the pioneer to actually start publishing books in the field of cardiovascular medicine. Earlier, there used to be only scattered some small data available. So this guy compiled all the data, all the research trials and everything. And that's how like the whole current modern cardiology took shape. So answer to question number 6 is option number B. And that's the standard presentation. Guy died during practice session. Doctor declared him dead on arrival. If Harry says like, why did he die? Then the answer is arrhythmia. I understand, but I hope I've been able to explain to you that the direct and the indirect causes had to be explained. Okay, so 6th is sorted, guys. We come to the 7th one. This is again a repeat from last time's paper only, that which of the following conditions does not share the same initial mechanism leading to heart failure as the others. So I'll expect answer from you guys. I'll do some theory writing here so that I can explain this better. Yeah. You see, in anemia, there is always a disproportionate tachycardia because the oxygen carrying capacity of the blood is lesser. So when the heart rate will increase disproportionately, it will always result in increase in fuel consumption, and there's a limitation of supply. Beyond a certain limit, heart cannot provide oxygen, so the heart will ultimately will not be able to keep up and will begin to fail. So when it comes to anemia, or when it comes to fever, or when it comes to thyrotoxicosis, in all of them, there is a disproportionate tachycardia, which will result in a tremendous increase in the oxygen demand of the heart. But there is a limited supply. So there is a mismatch between the demand and supply. Like I said, the demand is much more and there is a limited supply. So therefore, we use the word high output cardiac failure in these patients. But when it comes to high salt intake, then salt will be like not causing a tachycardia. It will increase the peripheral resistance in the body. When high salt intake, then I can say like people with hypertension. I mean, it predisposes to an increase in the blood pressure value in a patient, and therefore the stress on the heart would be coming up. So the odd man thing in this particular question is option number A. The answer to 7th is A. I had options between A versus B. Let me give elaboration for anemia again. लेबर रूम में तो सारे काम किए हो ना, और आपने देखा होगा ग्रैंड मल्टीप्लायर आती है रात को 3 बजे, आपको नींद आने लगती है, ग्रैंड मल्टीप्लायर आ गई, हीमोग्लोबिन 6 और हस्बैंड ने अपना मोबाइल फोन बंद कर दिया क्योंकि उससे तो ब्लड देना नहीं है, आप फोन करवाओगे भी तो फोन उठाएगा नहीं। अगर एक ग्रैंड मल्टीप्लायर रात को 3 बजे आपके हॉस्पिटल में आई है, उसके हस्बैंड ने उसको बोला कि बोलियो है ही नहीं, यहाँ से चला गया पता नहीं कहाँ पर, एंड शी इज लाइक मेकिंग अ सॉरी फेस, अनबुक्ड पेशेंट, not registered with ASHA worker, comes at 3 o'clock in the night with a hemoglobin of 6. उनको पता है कि आप अपना खून निकाल के दे दोगे. Doctors have a good heart and therefore doctors might be some interns, they might say bechari and they might give blood to her, but then this is a habit for these people. Sir, at a hemoglobin of 6 in a patient, the oxyhemoglobin in the body will be so less that delivery of fuel is less. So therefore there will be heart failure that will be occurring because myocardium को oxygen ही नहीं मिलेगा, so she will go into heart failure. And the first examination finding a heart failure, the earliest examination finding a heart failure is a disproportionate increase in the heart rate. I mean, I've always said one of the earliest findings in heart failure is a tachycardia. It's a compensatory mechanism that is happening in a patient. So the answer to this question is option number, I mean, B is the reason here. And most of the time, yeah, I can understand सारे ही, पर अभी तो बड़ा आज सरप्राइजिंग एक हुआ आया कि अगर एक डॉक्टर जो है उसके ऊपर कोर्ट केस है और डॉक्टर की डेथ हो जाती है तो हिज फैमिली इज लाइबल टू पे द डैमेजेस. I don't know, bar and bench का notification I was came in my feed, so I did not have time because I had to come for this. But if this is true, I mean, I don't know, मतलब अगले जन्म 7 जन्मों का एसोसिएशन बना लिया, 2 जन्मों का एसोसिएशन बना लिया, that if a doctor has, you know, a medical legal case against him and there's some damages he has to pay and he's not able to pay, or if he dies, then the responsibility is on the family. So crazy. गौरव ने बिल्कुल सही बोला, मेरे बच्चों ने क्या किया, मेरे होने वाले बच्चों ने क्या किया. बट दिस इज हाउ थिंग्स आर. सो yeah, they keep on, they keep on. See, for them it is a PR, that's just a PR exercise. खैर, तुम्हारा तुम्हारा जो काम है मेरी ओपिनियन में, that would be to like we need to go through the legal document obviously to look at the pros and the cons and like why this notification is there. But at the same time, I want to say that we have to be theoretically strong, and like we just need to do our things properly. Chalo. Okay ji, fine. Yes. Coming to the next question, we have this lady. She's SCL70 antibody positive, and there's a progressive dyspnea due to severe pulmonary artery hypertension. So the first line the question से तुम्हें ये तो समझ में आ गया कि वो स्क्लेरोडर्मा की बात कर रहा है, and the leading cause of death in scleroderma happens to be PAH. The question is very simple: what IV drug would be given? So we give prostaglandins to the patient. So in for management of severe pulmonary artery hypertension, where the wedge pressure would increase, yeah, when the pressure of the pulmonary artery is going from more than 20, definition is more than 20, it could be going up to 40, 60, severe one. So we might have to use IV prostanol in the patient. So the answer for this question is option number B. I wanted to introduce one easy question in between so that at least I give you a breather, because a couple of them previously you had to struggle a bit, and then it would be mixed back in like that in the paper also, that sometimes you'll be blinking at the histopathology slide and say कि अच्छा ये भी हो सकता है, ये भी हो सकता है, right? And then you'll say, okay man, this is so simple. So I assure you that you will be able to do the paper. It's just that that persistence for sitting for that continuously long hour, that is what is warranted. Okay, inhaled nitric oxide test that is required. Yeah, vasoreactivity test for diagnosis. Let's move to the 9th question today. This female comes with history of rheumatic fever, shortness of breath, loud S1. So we know that there is, why not C? So beta inhaled likha na. Sorry, intravenous likha na. So because it is written in intravenous infusion for a condition, that's why it is epoprostenol. Otherwise, तो अगर वो intravenous नहीं पूछ रहा था तो oral drugs की बात करते हैं. Yes. There is a opening snap which is present. He has not written loud opening snap, but loud S1 लिख दिया उसने with the mid-diastolic murmur that increases in intensity on inspiration. Okay, तो यहाँ पे यार ट्रिक सिर्फ इतना ही है कि all right-sided murmurs tend to become louder with inspiration, so it will not be mitral stenosis, na? If I say you take a deep inspiration, I agree this is tricuspid stenosis. But when you will take a deep inspiration, then more blood will come in the right side of the heart. So I've tried to show a lot of blood coming in the heart. And because there's an obstruction present, so obviously subsequently there would be turbulence. But you can see from the line diagram, I've tried to show that inspiration में more blood comes to the right side of the heart. So the answer to this question will change over to exactly tricuspid stenosis. If this word was not in the question, बस वो INI-CET में यही होता है कि आप assume मत करा करो कि ऐसा लिखा है तो इसका आंसर यही होगा. You have to always look up at the pointers which are given. Question number 9 is not given to discourage you. Question number 9 is discussed to only encourage you to read the question more appropriately and not assume answers to the question. It said mid-diastolic murmur that increases in intensity on inspiration. Yeah, P2 part will come up, agreed. But at this moment, it is the aspect of right-sided murmurs becoming louder with inspiration, left-sided becoming relatively softer with deep inspiration. That is why the answer to this is option number A. Exactly. If this word was not given, the yellow marking was not given, answer will be C. If the yellow marking is given, then the answer would be given as option number A. That's the only thing that is to be taken in the patient. Exactly. So नहीं अभी भी C आ रहा है. तो sometimes that Instagram बोल रहा हूँ, that YouTube relay can be delayed also. The chat also comes late, So I think we are good to go as far as the ninth one is concerned. Exactly, Mithun, you are spot on for it, right? Like nowadays, they don't favor mentioning those signs. They just say come up with the findings. Okay. Coming to the next question, a 50-year-old patient had chest pain on climbing stairs for past 2 weeks, and there's a normal cardiac biomarkers with resting baseline ECG, and then cardiac stress test shows reversible ischemia. Considering that it is reversible ischemia, it means that the person is having chronic stable angina. There's blockages in the coronary artery of the patient, and he says which of the drug it would be recommended for this patient so that there is a primary prevention of major mortality event in this patient. नहीं बेटा, ये हार्ट फेलियर का क्वेश्चन नहीं। SGLT2 इनहिबिटर तो क्रॉनिक हार्ट फेलियर में बोलते हैं ना, कि अगर किसी पेशेंट को क्रॉनिक हार्ट फेलियर है, CHF है, वहां पे लाइक वी आंसर SGLT2 इनहिबिटर. The patient is suffering from blockages in the coronary artery. He is having a exertional angina. There is a chronic stable angina in the patient. यार आप सारे लोग ना हार्ट फेलियर से मिक्सअप कर रहे हो. एस इनहिबिटर और बीटा ब्लॉकर, ये सारी जो दवाइयाँ होती हैं, मतलब एस इनहिबिटर जो बोल रहे हो वो भी हार्ट फेलियर के लिए तो है. They are also for this only. Here our objective is primary prevention. For primary prevention we have to bring down the, I mean why is this happening? इसमें क्यों ब्लॉकेज आती है? क्योंकि LDL ज़्यादा होता है. अगर LDL कोलेस्ट्रॉल किसी का ज़्यादा है, कंटिन्यूसली मोर देन 100 है, तो that means that there would be physical blockage. Most Indians are having LDL values hitting more than 100 because of the chole bhature and all the snacks and all the things that we eat. Restaurant food, even the hostel food that you guys eat is like having palm oil. So LDL cholesterol is more. Therefore, if you decrease the LDL, the primary mortality will become lesser. The answer to this question is option number D. When will you answer beta blocker? If the question said that he's already had, like, you know, this particular guy, he already had an MI. Like if I say to a question, if I say to you that there is a post-MI patient, he already had a heart attack. And in this post-MI patient, there is already presence of ASCVD, that is atherosclerotic cardiovascular disease. Now, what are the drugs that I'll be using to prevent the chances of myocardial infarction in future? So one, I will obviously be using low dose aspirin in the patient. Along with low dose aspirin, I will also be using beta blockers. So beta blockers are answer if the question mentioned secondary prevention, like low dose aspirin, beta blocker, and obviously statins would be continuing in the patient, no? Then statins would anyway be continuing in the patient and you might achieve a target. यहाँ पे अब statin से target भी change हो जाएगा ना. अब मेरा जो target है वो normal population वाला नहीं रहेगा, that would be less than 70, and अगर diabetes वगैरह है तो फिर तो मैं 50 से कम जाना चाहूँगा. ये तो हमारा टारगेट 100 के आसपास होता है ना. सो द क्वेश्चन इज से भी किसी को अगर अभी एंजाइना की कंप्लेंट है, वो कहता है जी सीढ़ियाँ चढ़ने पे दिक्कत होती है, तो बैड कोलेस्ट्रॉल उसका बड़ा होगा, तो हमें बैड कोलेस्ट्रॉल ही तो कम करना है. सो स्टैटिन्स वुड बी यूज्ड इन द पेशेंट. ओके, नायसिन के साथ में बेटा वही चक्कर है ना कि फ्लशिंग होगी, और फाइब्रेट्स जो है वो तब यूज करने होते हैं जब ट्राइग्लिसराइड्स की मात्रा 500 के ऊपर. Only if we specifies triglycerides more than 500, that we will answer fibrates. Otherwise, first is obviously atorvastatin and then is ezetimibe. That's another question that came up in INI-CET, that अगर atorvastatin से control नहीं हो रहा है, like you wanted to achieve a 50% reduction in the value of LDL cholesterol, नहीं हो रहा है, right? I mean, you are aiming for the highest value, like you're giving high intensity statin max dose and it's not working. What will you do next? Then it is ezetimibe that would be added to the algorithm. Yeah, we can give that. Obviously, those drugs are like expensive ना यार, है ना? So at the time that जो आप comment कर रहे हो धानुष, that is a good answer, but at the same time, like they may not be available most of the time, and they are the subsequent resort that will be using in the patient. So initial is like statin followed by ezetimibe. Okay, fine. Yeah, exactly. Nachiket, you have a good point there. So B and D is okay, but like I have to select single answer, then primary prevention would be given as statins in a person. For beta blockers, the guidelines are mainly for secondary prevention. Okay, so 10th we are sorted. We can move on to, like we discussed, cardiovascular aspects. Let's look at now CNS component. I have deliberately like highlighted the answer here also because this is a PYQ where a single lesion was present. Now I want a justification from you guys, right? I wanted a justification of you guys why the answer is tuberculoma. I mean, why, right? The question is there. Yeah, exactly. There is no Scolex that is documented here. And also you will notice that when it comes to a neurocysticercosis lesion, it will be black. The neurocysticercosis lesion will be black. And then along with this black, you will be able to see some white. Let me just put up a white here. So like it will be black and a white, and here if you look at it, it is a white followed by black inside. Ulta ban raha na, pura white rim. There's a complete white rim that is present here. So ring enhancing lesion that is present in this case. Yeah, a bit of basal exudates can also be seen. A bit of basal enhancement can also be present. That could be going in favor of tubercular meningitis in a patient. So yeah, the correct answer for this one is a tuberculoma. And starry sky, I agree that starry sky to will be multiple lesions, but usually like they can give single lesion of NCC or they can give a single lesion of a tuberculoma. So glioma is a brain tumor, right? Glioma would be a brain tumor. And then what is the best way to differentiate? That would be MR spectroscopy. Like he has himself asked what would be the finding in a tuberculoma, then it would always be a lipid peak on a tuberculoma. Whereas with respect to neurocysticercosis, it would always be a like a amino acid peak present. But this was like just highlighted to bring to your attention that whatever be given in a question, every time you see a single lesion, then try to evaluate from the perspective of a scolex or black holes that could be present, and like the tuberculoma part in this particular case. Yeah, because this is a tuberculoma, this is not tubercular meningitis, right? Both do not mean the same, no? It is tubercular meningitis and tuberculoma don't imply the same, no? They do not apply the same. The treatment is the same conventional treatment only that we'll be using in a patient. The size of tuberculoma is also relatively bigger, and then the more important part is that white ring that was present and not a white dot that would be present. The differentiation can be made on the basis of MR spectroscopy. That makes it relatively easier for us to identify the two lesions. A brain abscess will have a lot of like there would then be history of fever present, and there would be lot of cerebral edema component that would be seen simultaneously. So brain abscess is a solitary lesion. And another thing is brain abscess can be having an air fluid level. No? Like if you say brain abscess, there has to be air fluid level that is present. A lot of cerebral edema component present, which is not documented in this patient. So we are sorted for the 11th one. Let's move to the 12th one. Yes. For this one, I just wanted to keep the answer on because the question said marked psychomotor agitation. So initially when the question came, like a couple of guys casually thought that it can be rabies, but then rabies will not have these empty areas present. No? That is like these clear vacuoles which are present here. That is sponge or a honeycomb appearance that is present. So considering the fact that this is a sponge or there is a honeycomb appearance, marked psychomotor agitation can be seen with both of them, right? It is the sponge appearance of the brain parenchyma, which is the, yeah, that is why we call it a spongiform encephalopathy. That's why we tend to call it a spongiform encephalopathy. So like don't get biased by the word psychomotor agitation and say that the patient was aggressive, so it is rabies. We need to mainly check out the brain parenchyma. Yeah, the spongiform appearance, that is the main reason why the answer in this question is option number B, that is prion. And a supportive test can be done in the CSF of the patient also. For that CSF finding, can you quickly tell me what is the protein in the CSF in prion disease? I'm talking about like variant Creutzfeldt-Jakob disease. Yes, somebody also mentioned MRI finding of cortical ribboning. Meanwhile, while you are like, commenting on this, let me just write that MRI finding of variant Creutzfeldt-Jakob disease, the important one for INI-CET, that is called as cortical ribbon appearance. Yes, protein 14.14.3. Exactly. Good answer there. Protein 14.3.3 present in the CSF would add more credibility to the diagnosis, and the brain biopsy in this patient who died would be having a spongiform appearance present. Dhanush, you're right. Tainted beef, but then it's not always tainted beef. No? It can be having genetic basis also. It's a disorder that can have multiple modalities of transmission. There would be PRPSC protein in the cytoplasm of the neurons, which will contribute to development of neurodegeneration. So PRPSC is just a finding that can be picked up on histopathology. What we can test is protein 14.3.3. Yeah, periodic sharp wave complexes in the EEG of the patient. Exactly. Yeah, see, if I say and if I look at the neuro inclusions that are present in this particular case, then most of the time the slides में बहुत ज़्यादा clarity नहीं होती ना, eosinophilic basophilic, because that color part what we thinking is pink, and ideally we think ideal pink and ideal blue. So I would not suggest you to like focus on the inclusion bodies in the neurons of the patient, because they show you classical Wikipedia image that comes right for like Lewy bodies or for Hirona bodies which are pink, and the Lewy bodies which are like bluish in color. But if you look at the actual exam images, then the color students were not able to pick up. So in my opinion, like the rest of the brain parenchyma is a better way to solve the question rather than for prion specifically, rather than trying to focus on the color of uh, the color of the inclusions present in the cytoplasm of the neurons. Yeah, no treatment available. So answered, yeah, periodic sharp wave complexes was a very good answer for this, for the EEG finding that can also be picked up. So we are sorted for the 12th one. Let's move to the 13th one. Here I've deliberately not kept the answer because I want you to just read and let your mind oscillate between left and right. So anytime they give you a question like this, first make up a mind map of what is actually going on in the patient. So there's a sudden onset weakness on the right side of the body. The patient's face is deviated towards the right side. So I'll use a finer font to say that in this individual, the face is deviated towards one side. The face is deviated towards one side, that is right. He is having inability to close the left eye. Inability to close the left eye. That's another point. And then he says, additionally, both eyes cannot look towards the left side in the patient. The most important thing for this question is the last line. That is, both eyes cannot look towards the left side of the patient, because for this you need a conjugate. This is what is called as a gaze palsy. What is happening in this patient is the key word that is given is the conjugate gaze palsy. If you are able to pick that up, remaining things will become a piece of cake. Conjugate gaze palsy is present. Now let me work out the data before you. Weber syndrome is always going to be involving the third nerve. So there has to be ptosis, there has to be like, manifestations has to say ptosis, and then should be saying that the eye is outward and laterally placed because lateral rectus activity will go unopposed. So Weber could be ruled out. And Wallenberg syndrome has crossed hemianesthesia, so and has multiple cranial nerve palsies also, like ninth nerve can be involved, then the 10th nerve can be involved. So there are multiple like 5, 7, 9, 10 that can be involved, but like 9 and 10th, that means bulbar palsy would be coming up, again not given in the question. So 2 could be ruled out, and now you're left between 2 only, that is Millard-Gubler and Foville syndrome, and both are having 6th as well as 7th nerve palsy. That is why he's describing that the patient is having a phase deviation. The moment you read up the word phase deviation, you can understand that he's talking about a 7th. And when he's talking about like the eye movement, conjugate gaze palsy coming up, that means that there is a 6th nerve involvement also occurring. The main concept in this question is that the nucleus of the 6th nerve is involved. That is going to communicate with the third nerve nucleus of the opposite side. You see, we both can look towards the left and we both can look towards the right. Like suppose if I say that a person has to look towards the left side, then on one eye the lateral rectus would be using, and on the other side the medial rectus would be requiring. And for this you need PPRF, that is parapontine reticular formation, which usually gets affected in Foville syndrome. So I think most guys were able to identify the fact that because the patient cannot, I just drew this diagram to highlight the conjugate gaze that should be happening, and that conjugate gaze is not present in this particular patient. So because gaze palsy is given, not lateral rectus palsy, that is why the answer to this question would be given as pontine stroke, that is Foville syndrome. Foville syndrome, the main thing to be remembered would be that there is a full gaze palsy, F for Foville, and the word is full gaze palsy. Whereas whenever it's gonna be like F for Foville and F for full, FULL gaze palsy, that means third and the sixth communication is gone. Whereas when it comes to Millard-Gubler, it is only gonna be a lateral rectus palsy that is occurring. Millard-Gubler is like only lateral rectus palsy, but the other side eye will not be involved. In Foville, it is a full gaze palsy. That nucleus of the 6th nerve is affected. It communicates with the nucleus of the third side of the opposite side. That PPRF communication is gone, and that's why this manifestation will be present. The correct answer to this question is Foville syndrome. What I will do next is under 2 minutes, I'll try to make you practice the core aspects related to the stroke syndromes here. Especially, I'll focus on the cranial nerves that would get involved, and you guys can do the talking in this particular patient. That is Weber syndrome. It has a third nerve palsy, and along with that, there would be contralateral hemiplegia. There would be a face involvement in a patient also. I'm not obviously writing ipsilateral, contralateral. I mean, understandably in stroke, the cranial nerve palsy will always be ipsilateral. The cranial nerve palsy would be ipsilateral, and the other manifestation would be contralateral. For non-Thingol syndrome, it is again third, but now there would be contralateral ataxia occurring in a patient. This is because of the involvement of the superior cerebellar peduncle, that the contralateral ataxia component would be coming. So it's by default stroke में सभी कुछ contralateral चलता है, so I'll write it that CL word on the top. Then is Benedict syndrome. In Benedict syndrome, it is B for basal ganglia. So here he will try to trouble you by writing words like that the patient is having resting tremors, or he might say that the person is having chorea. So when you read about B for basal ganglia involvement contralaterally with ipsilateral third nerve palsy, then it is going to be Benedict syndrome. So not too much of work to do. Third common. It is crus cerebri getting involved. It is superior cerebellar peduncle getting involved, and then it is going to be the involvement of the red nucleus, due to which the tremors and the chorea component would be coming in the patient. Somebody commented regarding that. Okay, ipsilateral, yes. So ataxia is contralateral, but third nerve palsy is ipsilateral. Then foveal. Foveal, as I said, it's the full gaze palsy. It is the full involvement. What I mean by full is that he will always say the word. It is obviously ipsilateral 6th and 7th nerve palsy that is occurring. There would be a contralateral hemiplegia that would be occurring in a person. Same thing written for this also. 6th and 7th nerve palsy with hemiplegia, but a bit difference. The word is full gaze palsy. That is the conjugate gaze palsy that would be occurring. For Millard Gubler, it will only be lateral rectus weakness. So at this moment, I deliberately spoke a little faster. There is no point of drawing those diagrams at the moment, but we were able to revise 5 pretty straightforward stroke syndromes. And now what we will discuss is the lateral medullary and the medial medullary part. What are the keywords that we'll be using? For the lateral medullary, the blood vessel involved is the vertebral artery more than pica. Medial medullary is the anterior spinal artery that is involved. For lateral medullary, the core thing will be the word crossed hemianesthesia. Like on one face, one side of the face, on one side of the face and opposite side of the body, it is the pain and the temperature that would be affected. So crossed hemianesthesia is like the main feature by which we are able to identify. Another thing can be, he can mention regarding arm weakness. He can say hypotonia of the arms. In any stroke syndrome, you always will be having spasticity, but here he'll be mentioning regarding the hypotonia of the arms, and then multiple cranial palsies would also be occurring, especially the 9th and the 10th that would be involved. So he might even mention things like can't drink, can't swallow. That's because of the bulbar palsy involvement that can come up there. For medial medullary syndrome, the answer would be mainly with respect to tongue deviation. Like he'll say that the doctor has asked the patient for tongue protrusion. It's a 12th nerve palsy with contralateral hemiplegia, everybody knows. The only thing is he will ask you regarding the tongue deviation. So it would be a ipsilateral. Like when you ask the patient to take his tongue out of his mouth, it would be ipsilateral tongue deviation with a contralateral hemiplegia that would be coming up. And that's obviously going to contribute to like chewing weakness, and even the speech in the patient can be affected. So locked-in syndrome is where the brainstem totally gets smashed, basilar artery occlusion, and that would be like what like that Formula One driver that I've spoken about, Michael Schumacher suffered from. Like the person is, his cortex is working, like at least he's aware of the surroundings, but the rest of the body cannot move because bilateral corticospinal tract involvement is there. Degeneracy syndrome would be contralateral. It's a manifestation of small vessel stroke, and it would be involvement of the thalamus. So contralateral burning sensation in the body would be present, especially if you touch the patient or if you do mopping of the patient with normal temperature water also, there would be like searing pain experienced by the patient. Okay. Yeah, thalamic is degeneracy. Exactly. Okay. So moving ahead, I invested some time into the common varieties of stroke, and like most guys were spot on to pick up the full gaze palsy. Let's move on to the 14th one here. This is a Parkinson disease patient. He's on levodopa, carbidopa, and now he's having these episodes of muscle rigidity. He's having these episodes of rigidity and inability to move because of adherence to medicine. So there's off phenomenon that is occurring and is lasting for a very long time. So he says, what is the best way to decrease the off phenomenon in the patient? Yes, guys, best drug to reduce the off phenomenon in the patient. Via the non-dopaminergic. Yeah, rescue therapy. But then rescue therapy, apomorphine will work via the dopaminergic system only. Na? Why apomorphine is a good answer. I mean, apomorphine can be given subcutaneously, but then if you look at option number D, it will be working via the dopaminergic system only and will tend to take care of the off phenomenon in the patient. So safinamide as A that came in, that is again a good drug to reduce the off phenomenon. The question is about a new drug, no, that non-dopaminergic. Wow, Prashant, great. P for you. Non-dopaminergic pathway to reduce indirect pathway overactivity. That's the word that is to be picked up, and that's a new drug, guys. That is istradefylline. The answer to this particular question is yes, yes. JVR, you got it right. It is A2A blocker, that is istradefylline. It's adenosine receptor antagonist that's to be picked up. The answer to this question is option number B. It's like line to line from Harrison only that the question has been picked up. Drug works via non-dopaminergic pathway to reduce indirect pathway overactivity and take care of the off phenomenon in the patient. So answer to this question is option number B. Just wordings matter. Like INI-CET is very particular about it, that the lines or like the phrasing of the question is very, very, very particular. Unlike in NEET, where like some questions are very vague terminology and it's very open to speculation and debate. In INI-CET, I think they take pretty due care because they have to conduct a paper twice a year, so they do a good job by making questions very, very aptly worded. Okay, Ji. So answer to 14th is Bombay. As far as cranial nerves involved are concerned, I understand. I understand. That would be like I understand. Drop is the most difficult thing for any doctor, but you just need to sit and persist, and you have like fair amount of idea about how things are placed. Unlike the freshers who might be just simply euphoric. Not taking credit away from them, but yeah, I think you just need to just motivate yourself to show up every single day. Both of them will be having optic nerve involvement for multiple sclerosis. I'll tell you the differentiating features between the two in a couple of minutes from now. Then for anterior cranial fossa trauma, it will be the ophthalmic nerve that would be involved. There would be a CSF rhinorrhea that would be there. For middle cranial fossa fracture, Peter's part of the temporal bone, it is the facial nerve injury that would be occurring. Leprosy, you guys can comment, raise ICP, I'll do the fact, it is sixth nerve palsy. Sixth nerve palsy is which we read for raise ICP, false localizing sign, Wernicke's encephalopathy. Which is the commonest cranial nerve that is involved in leprosy? भाई cranial nerve की बात हो रही है, peripheral nerve की बात नहीं, ulnar नहीं यार, cranial nerve सुनो तो सही. It is the facial nerve. Ulnar nerve तो peripheral nerve होती है ना यार. Facial nerve is the one. Yes, yes, it is the facial nerve that would be involved. Then is Guillain-Barré syndrome also is the facial nerve, but this time it is bilateral. Because it is a bilateral facial nerve involvement, that's why the word here would be facial diplegia. Then is Millard-Gubler syndrome. Millard-Gubler would be having sixth nerve palsy as well as seventh nerve palsy, two of them together, but it is a lateral rectus palsy only. Okay, then is Miller-Fisher syndrome, that will be having ophthalmoplegia, ataxia. यहाँ पे triad होता है. The triad that they love to ask is OAA, that is called as ophthalmoplegia, ataxia, and then is areflexia, because anyway it's a variant of Guillain-Barré syndrome, so areflexia has to be there because the demyelination component here. So in this case, what is the nerve that would get involved for the ophthalmoplegia component? Then answer would be third nerve palsy. In Miller-Fisher syndrome, it's again a third nerve palsy that would be responsible, and in contrast with Wernicke's, which is the sixth one. Then comes PCOM, diabetes mellitus, midbrain syndrome, Weber. In sabhi mein answer third nerve palsy hai. I have done this activity so that I can just make you practice the nerves which are involved in various situations. They can be isolated questions or they can be hints to summarize all the neurology into, especially because they focus on nerves getting involved. So that is why I thought that yeah, in diabetes mellitus, your right pupils are spared because of the arrangement of the fibers, but the activity without pupillary involvement, JVR, I agree to it, but this activity was done so that at least we get a fair amount of idea what are the nerves that are getting involved, and in case you do this activity fast by yourself, that means that you have a fair amount of understanding regarding how the disease processes would be evolving. Now, as far as the theory part of multiple sclerosis and um, neuromyelitis optica is concerned, I'll move the slide up. I'll come back to it because otherwise, if we do only theory, it doesn't make sense. So I'll move up this. I'll come back to it shortly because neuromyelitis optica again a super important component where the diagnostic criteria, that is A, B, C, D, E, will be asked to you. So I'll come back for that. But then becomes a little boring because otherwise only the theory part, if it is practiced, tends to make you dull. So let's keep the ICP also sixth nerve, doctor. Yeah. Exactly. In raised ICP sixth nerve, the reason I think I've said it since you asked a query, I'll address you. Meanwhile, the remaining people can take care of this question. You see, sixth nerve jo hoti hai na beta, that has the longest subarachnoid course or intradural course. So it is going through that area where the pressure in the brain is more. I mean, raised ICP means pressure in the brain is more. तो बेचारी ना innocent bystander है और सड़क के कॉर्नर में कोई खड़ा गाड़ी मार के चली गई, इनोसाइड बायस्टैंडर। वैसे ही वहाँ पे क्या, 6 ना तो कोने से जा रही थी पर वहीं पे प्रेशर बढ़ा हुआ था, तो बेचारी इन्वॉल्व होगी, तो तभी उसको फॉल्स लोकलाइजिंग साइन बोलते हैं। चलो जी, लेट्स हैव आंसर्स फ्रॉम यू गाइस फॉर ट्रांसफ्यूजन बायोलॉजी। I am today having a patient. He is having acute myeloid leukemia. We have given a transfusion of a SDP, and the guy is having breathing difficulty. There's a fever, there's chills, there's hypotension, bilateral infiltrates. So, okay, more people, please. Transfusion related acute lung injury in a patient. Okay, that's a very good answer. ट्राली विद इन 30 मिनट्स उसको स्टार्ट हुआ है, तो 4 आवर्स वाला वो डेफिनेशन भी सेटिस्फाई हो रहा है। सो गोज इन फेवर ऑफ डेवलपमेंट ऑफ ट्राली इन अ पेशेंट। ओके, तो क्या ट्राली में ऐसे हाई ग्रेड फीवर विद चिल्स एंड राइगर्स आएगा? ट्राली के साथ में हाई ग्रेड फीवर्स विद चिल्स एंड राइगर्स आएगा? टाको तो नहीं है, टाको में तो बीपी बढ़ जाता। इन टाको द ब्लड प्रेशर विल ऑल्सो बी मोर, जेवीपी विल ऑल्सो बी मोर। इन ट्रांसफ्यूजन रिलेटेड acute lung injury in the patient, the blood pressure will remain normal, या तो हाइपोटेंशन हो रही है, द जेवीपी विल रिमेन नॉर्मल, एंड इन ट्राली यूजुअली लाइक दैट हाई ग्रेड फीवर विद चिल्स एंड राइगर्स नहीं होगा। गाइज आप मिस कर रहे हो कि प्लेटलेट्स के साथ में बैक्टीरियल इन्फेक्शन ट्रांसमिट होने का रिस्क सबसे हाईएस्ट होता है, बिकॉज प्लेटलेट्स आर स्टोर्ड एट रूम टेम्परेचर। बिकॉज प्लेटलेट्स आर स्टोर्ड एट रूम टेम्परेचर, द चांसेस ऑफ बैक्टीरियल कंटेमिनेशन विल बी वेरी वेरी हाई। प्लीज पिक अप द वर्ड ब्लड ट्रांसफ्यूजन नहीं लिखा था, आप ट्राली टाको के बारे में सोच रहे हो। आई एग्री टू द फैक्ट दैट टाको एंड ट्राली हैज टू बी केप्ट इन माइंड, but since the patient has received a SDP unit, the guy with acute myeloid leukemia can be having can be having like low platelet count. In any patient with low platelet count, the problem would be that, I mean, anybody with low platelet count, I can say, like the person would be having bleeding, and I don't want him to have any life-threatening bleed, especially if the platelet count is less than 10K in a setting of like, fever also present. So in this particular case, it's a transfusion transmitted infection that is present. Somebody said mismatched transfusion reaction. तो यार मिसमैच ट्रांसफ्यूजन रिएक्शन में तो फिर देन देयर वुड बी अदर मैनिफेस्टेशंस लाइक डीआईसी के जो फीचर आने शुरू हो जाते हैं। देयर शुड बी फ्लैंक पेन दैट शुड बी गिवन इन द क्वेश्चन, देयर शुड बी मैसेज ऑफ लाइक एटलीस्ट, I mean, the DIC, that flank pain, something like that particular point has to be there. So, yeah, within 30 minutes, because infection went in the body of the patient, the platelets were having bacteria present, and the moment you send bacteria in the body, the patient will become sick. So, answer to this is C, septic shock, man. The guy is going into sepsis. That is why there's a high grade fever, there is a chill, there is a hypotension, hypoxia, and then sepsis can cause also development of ARDS in a patient. Septic shock and sepsis can also result in development of like person. One of the leading causes of ARDS is pneumonia, and after that is sepsis only. So within, if you give transfusion, suddenly somebody is deteriorating, either it will be anaphylaxis, right? Mismatched or anaphylaxis, either of the two. So with allergic reaction, then there should be some manifestation. अभी mismatched है तो there should be some wheals, some allergy, some redness, कुछ तो दिया होता है कि उसको खुजली होना शुरू हो गया, there was pruritus present in a patient, like there was no, if you say mismatched, right, there has to be, or there's anaphylaxis, then there has to be like these kind of data which are given in the question. So considering the transfusion in this patient, yeah. No, it is TTN, transfusion transmitted infection is the first one. There's an algorithm that is given, I've discussed in the hematology section of Sunna usko, that is transfusion transmitted infection is the one that develops in the first few hours. If the fever is more than 1 degree for 1 degree Celsius or more, fever rises by more than 1 degree Celsius, 37 से 38 plus hai, and within like few hours or minutes of transfusion, first to be thought of is transfusion transmitted infection. Okay, Ji. So answer to 15th is option number C. What is the most common complication of blood transfusion, guys? No, it's not preformed toxins. It's bacteria going in, sir. Straight away bacteria that are going in. They'll cause an endotoxic shock in the patient. No? What is the most common complication of blood transfusion? Yeah, febrile non-hemolytic transfusion reaction. If the question said what is the most common complication of blood transfusion leading to death, then it is obviously TRACO, that is transfusion associated circulatory overload. And that TACO, transfusion associated circulatory overload, will always be in the vitals. BP will also be more, JVP will also be more, and the values of BNP, that is B type natriuretic peptide, will also be elevated. Usually they tend to squeeze in one question on transfusion reaction, so I thought I could just open your mind to all kind of possibilities in the question. Then is the leading bacterial infection due to repeated packed RBC transfusion. Yes, guys. What is the leading? I'll give options also. Like, options. While the question is in front of you, Staph aureus is one, Yersinia is another one, Listeria is another one. You want me to give more? Okay. Acinetobacter is another one. Yes, guys. Like this particular patient. Yes, guys. Leading bacterial infection due to repeated packed RBC transfusion. Yes, yes, guys. Mm-hmm. भाई रिपीटेड पैक्ड आरबीसी जब किसी को बार बार ब्लड ट्रांसफ्यूजन देते हैं तो कौन सा ऐसा पेशेंट होता है जिसको बार बार ट्रांसफ्यूजन देते हैं? थैलेसीमिया ना। जो थैलेसीमिया वाले बच्चा होता है उसको तो हर 1.5 महीने पे 2 महीने पे आप ट्रांसफ्यूजन देते हो। अगर थैलेसीमिया वाले को बार बार ट्रांसफ्यूजन दोगे तो उसके शरीर में आयरन की मात्रा बढ़ जाएगी, बिकॉज व्हेन द आरबीसीज विल ब्रेक डाउन द आयरन विल एक्यूमुलेट इन द बॉडी। अब बताओ इनमें से आयरन लविंग बैक्टीरिया कौन सा है? यस गाइस, कपल ऑफ पीपल, दीपक, कुशवाहा, डॉक्टर ऐश। यस एग्जैक्टली, आयरन लविंग बैक्टीरिया कौन सा है? लिस्टीरिया। बिकॉज द क्वेश्चन सेड ट्रांसफ्यूजन डिपेंडेंसी, उसने डायरेक्टली नहीं लिखा, उसने बोला पैक्ड आरबीसी बार बार मिल रहे हैं किसी को, तो व्हेन यू गिव पैक्ड आरबीसी टू समबडी अगेन एंड अगेन एंड अगेन, देन आयरन लविंग बैक्टीरिया लिस्टीरिया मोनोसाइटोजिन लेवल्स विल इंक्रीज इन द पेशेंट। जो आप स्टाफ बोल रहे थे यार, वो अगर आप इसमें बोलते ना, दो इसका भी आंसर स्टाफ नहीं है ना। I keeping the same options. What is the leading bacterial infection due to blood transfusion? What bacteria will grow in the blood bank at 4 degrees Celsius? What bacteria will grow in the blood bank at 4 degrees Celsius? Yes, guys. Yeah, Yersinia. Yes, leading bacterial infection due to blood transfusion would be Yersinia. Exactly. So just wanted to bring to your attention the infection component also. Obviously, Taco and Trali questions you are able to do. Febrile non-hemolytic you will be able to do. पर वो उसके beyond भी तो पूछ रहा है ना। वो ट्रांसफ्यूजन ट्रांसमिटेड इन्फेक्शन के बारे में पूछ रहा है। भाई ट्रांसफ्यूजन ट्रांसमिटेड इन्फेक्शन, आई डोंट मीन HIV हेपेटाइटिस बी, तो टेस्टिंग से रूल आउट कर लेंगे। आई एम टॉकिंग अबाउट दोज विच आर लाइक बैक्टीरिया, नास्टी bugs that grow in the blood bank environment. So at this moment we are sorted for 15. The answer is option number C. Let's do one more. Just zooming out a bit. I think it's a little available, just got broken in the slide partly. Bacterial beta, bacterial here. This man came with low backache, which is worsening at back pain worsening at night, and then he's having fatigue, recurrent infections, and then CRAB features are given in the question. Like lab is showing to be hemoglobin to be less, the calcium of the chap is elevated, creatinine is deranged, ESR is elevated, the bone marrow study is shown here. You can see a flame cell here. In the histopathology component, you can see a flame cell. If I zoom it further, you can see some inclusions inside the cells. These are like in the nucleus. In the nucleus also, you can see some inclusions in both. These are called as Dutcher bodies. So if I incorporate all of these manifestations है ना, जैसे कि यहाँ पे Dutcher bodies भी हैं, is present, so Dutcher bodies, and then the flame cells that are present. So all of these would contribute to diagnosis as yeah, if there's intracytoplasmic, I'll say Russell bodies. In the nucleus, then I'll say it is like Dutcher bodies. So diagnosis of the patient is flame cell, Mott cell, Dutcher body. So everything, including the features of CRAB, is telling me that we are dealing with multiple myeloma. So considering that we are like done for the diagnosis of this patient, now we need to analyze the options. And he says which of the following is correct about this condition. So yep, I'm getting a C. यार वो यूरिन में बीटा 2 ट्रांसफरिन लिखा है ना, बीटा 2 माइक्रोग्लोबुलिन लिखा और वो ब्लड में देख रहे होते हैं। यहाँ पे दो चीज का गलती है। सी क्यों इसका आंसर नहीं है? आई कम टू ए ऑल्सो। सी इज नॉट द आंसर, क्योंकि एक तो यूरिन लिखा हुआ है और दूसरा बीटा 2 ट्रांसफरिन लिखा हुआ है। बीटा 2 ट्रांसफरिन तो सेरेब्रोस्पाइनल फ्लूइड में होता है ना, रिमेंबर वो नाक पे मुक्का मारा, नाक से राइनोरिया हो गया उसको, CSF राइनोरिया, तो कॉटन का प्लेजेट डालेंगे एंड विल चेक फॉर द CSF राइनोरिया इन द पेशेंट। It is urinary beta 2 transferrin. हम क्या देख रहे होते हैं? We check for two things in the blood of the patient. That is, one, we will check for beta 2 microglobulin. A lot of you, in a rush to answer the question, mixed up between beta 2 microglobulin, and second thing that we check is obviously serum albumin. So, in fact, this is one of the most important statements for multiple myeloma that they love to ask in the exam. Since like after transfusion, I thought incorporate a blood cancer here at the moment. So prognosis is determined on the basis of The prognosis in multiple myeloma is determined on the basis of beta 2 microglobulin as well as serum albumin. So that is like ruled out. He says which of the following is correct? Yes. B बनता नहीं ना यार, increase albumin नहीं होगा ना. It is paraproteins in the urine. Why albumin is wrong is because albumin तो यहाँ बढ़ता नहीं ना, यहाँ तो incomplete light chains बनते हैं जो कि positively charged proteins होते हैं. क्योंकि positively charged proteins होते हैं तो उनको paraproteins बोलते हैं, तो B भी नहीं होगा. और ऑटोनोमिक डिसरिफ्लेक्सिया भी नहीं है, तो एक्सक्लूजन से करना ना. इट इज अनायन गैप दैट विल बी लेस इन द बॉडी बिकॉज पॉजिटिव चार्जेस बढ़ गए ना, है ना. तो उसको काउंटर बैलेंस करना. हमें अनायन गैप इज अ डिफरेंस ऑफ पॉजिटिव एंड नेगेटिव चार्जेस. तो यहाँ पे पॉजिटिव चार्जेस, सोडियम नहीं बढ़ा, पॉजिटिव इलीगल ऐसे बोलूंगा, इलीगल पॉजिटिव चार्जेस बढ़ गए. तो इनको काउंटर बैलेंस करने के लिए बॉडी को नेगेटिव चार्जेस बढ़ाने पड़ेंगे. अनायन गैप कैसे कैलकुलेट करते हैं? आई जस्ट 2 30 सेकेंड सेइंग ऑफ दैट. सोडियम इज द पॉजिटिव चार्ज और उसमें से सब्ट्रैक्ट करना होता है नेगेटिव, दैट इज द क्लोराइड एंड द बाइकार्बोनेट. लॉजिक और रैशनल क्या है कि जो पैराप्रोटीन्स होते हैं पॉजिटिव होते हैं, तो उनको काउंटर बैलेंस करने के लिए बॉडी को इलेक्ट्रोन्यूट्रलिटी मेंटेन करना है, तो इट विल कॉज अ रीअब्जॉर्प्शन ऑफ क्लोराइड एंड बाइकार्बोनेट इन द पेशेंट. तो नेगेटिव चार्जेस इतने ज़्यादा बढ़ जाएंगे, इतने ज़्यादा बढ़ जाएंगे कि नेगेटिव वैल्यू पॉजिटिव से ज़्यादा हो जाएगी, तो अनायन गैप की वैल्यू लो हो जाएगी. Right? The reason for this is why the serum anion gap is low in multiple myeloma is because to balance the electroneutrality component, yeah, we can have a pseudo hyponatremia. The leading cause of death is not renal failure. The leading cause of death in the patient is infection. The leading cause of death in multiple myeloma happens to be infection, not renal failure. If he says what is the cause of renal failure, then agreed. It is going to be hypercalcemia. So if he says that the kidneys are injured in multiple myeloma, and what is the reason for death of the reason for kidney getting affected, then hypercalcemia would be primary reasons, followed by Bence-Jones protein, and third is hyperviscosity because blood गाढ़ा हो जाता है, प्रोटीन ज़्यादा बढ़ने शुरू हो जाते हैं. So in this particular patient, it is like multiple aspects that are discussed, but for this question, you have to work out the negative. You had to work it out on the basis of exclusion, right? So INI-CET is gonna be not direct questions. It's like we have to work out the data here. In the previous question, no mention of cause of transfusion. So possibility of hypovolemic shock or DIC due to यार वो लास्ट का जो वर्ड लिखा ना, GI bleed due to PUC. नो यार, GI bleed क्यों होगा? मतलब हम प्लेटलेट दे रहे हैं पेशेंट को ना, तो इट इज लाइक एंड फीवर विद चिल्स एंड राइगर्स, so that goes more in favor of infection. Yeah, IL-6 and immunoglobulins are the ones here. No, most common is light chain involvement. No, it is hypercalcemia according to Harrison. And in some books it is mentioned light chain. तभी मैंने second point बोला. First is hypercalcemia, second is the light chain component. तो राहुल आप मुझे क्वेश्चन का स्नैपशॉट भेजना marwahmedicine@gmail पे. I'll assist you in that. The textbook says first is renal failure का cause is hypercalcemia, then is the tubular damage due to uh, due to the obstruction of the tubules by Bence-Jones proteins, and third is the hyperviscosity syndrome. Okay, G, fine. Moving ahead. This farmer came with black warty cauliflower lesions on the dorsum and the sole of the foot. And then there is like presence of these fungus which is having melanin in the fungal wall. So he says melanin मतलब black fungus है. हम बात कर रहे हैं ब्लैक फंगस की, क्योंकि ब्लैक फंगस का मतलब ये होता है कि उसमें मेलानिन प्रेजेंट होता है. तो उसने बोला कि मतलब इनमें यस 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 द डायग्नोसिस ऑफ दिस पेशेंट, क्योंकि कॉलीफ्लावर ग्रोथ्स लिखा हुआ है और ब्लैक फंगस है, तो द डायग्नोसिस ऑफ द पेशेंट इज क्रोमोब्लास्टोमाइकोसिस. Another way to solve this question is the word sclerotic bodies, which are actually medullary bodies, but the medullary word is not given because it will deliberately be concealed. But considering it is chromoblastomycosis in this patient, the question says which is not a causative agent. तो black fungus में तो Fonsencia है, Cladophila, Phyllophora, Phyllophora, but then not Coccidoidoides immitis. So the answer to this would be option number D. Yes, it's the black fungus that had to be picked up. चलो, that just eases of the pressure a bit because suddenly वो बड़े सारे cranial nerves आ गए थे, तो I thought I'll just to ease off the pressure. Let's play and continue playing the game of question and answer at the moment. So the next question says this is a 45-year-old man. He came with progressing difficulty, and then there's a cough, there's a weight loss, and certain findings which are given are very very classical. Like there are amphoric breath sounds with increased vocal resonance and hyper resonant note on percussion. तो हाइपर रेजोनेंट नोट ऑन परकशन पढ़ते हैं, साथ में हम ये भी पढ़ रहे हैं कि एम्फोरिक ब्रेथ साउंड्स है। तो इनिशियली तो लगता है कि भाई दिस कुड बी अ पॉसिबिलिटी ऑफ अ न्यूमोथोरैक्स, लेकिन न्यूमोथोरैक्स में तो एयर एंट्री एब्सेंट होती है ना, यहाँ पे तो हमें एम्फोरिक ब्रेथ साउंड्स मिल रही हैं। देयर इज अ इंक्रीज वोकल रेजोनेंस दैट इज प्रेजेंट इन अ पेशेंट, सो द आंसर इन दिस क्वेश्चन इज ऑप्शन नंबर सी, दैट इज लंग कैविटी. The word is amphoric breath sounds word are given. Pneumothorax will always be saying the word which initially came up was pneumothorax will be having decreased breath sounds. You know, if I say the word absent air entry and if I say the word absent breath sounds, then it makes sense. But here it is like amphoric breath sounds that is making easy for you to answer. This is option number C, that is the lung cavity. So fairly simple here. Okay, somebody said increase vocal resonance. So from the perspective of consolidation, but then consolidation में जो breathing होगा वो different होगा ना. In consolidation, the breathing that is present would be answered as bronchial breathing. Here, the word amphoric breathing alone is sufficient. You know, you are to mainly focus on the word amphoric breathing for this patient. And again, I'll say why A is not the answer, because it will have a dull percussion note. It will not have hyperresonant. No? If you talk about pneumonia, pneumonia will have a dull percussion note present. So yeah, Xavier, answer is not A because of the following reason. ब्रोंकियल इसको एक्सक्लूजन से करना था, अभी वो भी बताता हूँ. आपने बचपन में ना कोक पिया था? आजकल तो जैसे पीपल डोंट ड्रिंक कोक या पीपल डोंट ड्रिंक फैंटा, बट पुराना फैंटा का बोतल देखे हो? तो फैंटा के बोतल के ऊपर अगर आप अपने लिप्स के ऊपर लगा के उसको ऐसे फूंक मारोगे ना, तो उसके ऊपर ग्लास के ऊपर ब्लो करने की आवाज आएगी. फैंटा का बॉटल लेना, बचपन में जरूर किया होगा. फैंटा या कोक का जो ग्लास का बॉटल होता है, अगर आप उसको ऐसे बॉटल को पकड़ के नियर लिप्स एंड यू ब्रीथ आउट, तो आपकी एयर जब वो फैंटा का छोटा सा बॉटल को ओपनिंग के ऊपर से निकलेगी ना, तो सीटी सा बजेगा. that sound that is created is what is called as amphoric breathing in a patient. So yeah, that is amphoric sort of, that is what I'm saying, that is what I'm saying, amphoric breathing. I'll say that again. फैंटा या कोक का बॉटल बचपन में लिए होगे, उस पर फूक मारा होगा, तो उसमें ऐसे मतलब यू ब्रिंग दैट ग्लास का एज नियर योर लिप्स एंड ब्रो आउट, तो जो हवा जब निकलेगा ओवर दैट स्मॉल ओपनिंग ना, दैट विल प्रोड्यूस दैट एम्फोरिक ब्रीदिंग. नाउ व्हाट यू आर सपोज टू डू फॉर दिस क्वेश्चन इज आइडेंटिफाई. हाइपर रेजोनेंट नोट लिखा है तो भाई न्यूमोथोरैक्स भी होता है, पर उसमें तो एयर एंट्री एब्सेंट होगा. एंड इफ आई टेक इनटू कंसिडरेशन लंग कंसोलिडेशन में डल परकशन नोट होता है, ब्रोंकियल ब्रीदिंग होती है. तो आपको अगर एम्फोरिक ब्रीदिंग नहीं भी पता था तो उसके बिना भी आप क्वेश्चन सॉल्व कर सकते हो ऑन द बेसिस ऑफ एक्सक्लूजन देयर. सो आंसर टू दिस क्वेश्चन इज सी. या आई मीन वो तो फिर हम मतलब मल्टीपल एक्सपेरिमेंट्स कर सकते हैं. दैट वाज द क्लोजेस्ट आई कुड थिंक ऑफ. Pneumatocele is a cause of lung abscess ना बेटा, that could be causing a abscess. Abscess will not cause amphoric breathing. ये उसमें तो पस होती है ना, टीबी का जो कैविटी होता है, that's what is the one that we talking about. नहीं भाई, शुगर वाली कोई भी ड्रिंक अच्छी नहीं होती है. शुगर, इंडियंस को शुगर डाइजेस्ट नहीं होती है. सर लंग कोलैप्स में अगेन जो फाइंडिंग आएगी, दैट वुड बी डिक्रीज एयर एंट्री ना. if imagine a part of your lung is collapsed, the first thing that will happen is a reduced air entry in the patient. That's the main differentiating feature. Most of the time it is a ball valve effect that could be occurring due to a tumor. Okay, moving to the next one. A AIDS patient is coming with cough and shortness of breath, and like there's a use of accessory muscles of respiration, and then the guy is having a dull note on. मैंने डल नोट बता दिया अभी आपको, ब्रोंकियल ब्रीदिंग भी है. तो कंसिडरिंग डल नोट एंड देयर इज अ ब्रोंकियल ब्रीदिंग विच इज प्रेजेंट, देन वी विल से दैट वी डीलिंग विद अ बैक्टीरियल इन्फेक्शन. एंड यूजुअली द कॉमन बैक्टीरियल इन्फेक्शन इज न्यूमोकोकस. और न्यूमोकोकस में तो बायो होता है. बायो मतलब बाइल सॉल्युबल, और बायो मतलब देयर इज ऑप्टोचिन पॉजिटिविटी. दिस इज बायो पॉजिटिव न्यूमोकोकस. बाय बायो मीन बाइल सॉल्युबल optogene sensitive organism. This is I think last time's INI-CET question only, and all you had to pick up was the microbiological details there. अल्फा हेमोलिटिक मतलब वो आप उसके आसपास में ग्रीन कलर का रिंग आ जाएगा हेमोलिसिस का. सो अल्फा हेमोलिसिस, बायो पॉजिटिव एंड एनकैप्सुलेटेड ऑर्गेनिज्म. The answer to this question is option number A. Yeah, inulin fermenter and optogene sensitivity. Don't go by CD4 count. Don't solve the question by CD4 count. CD4 count is never diagnostic. It is never diagnostic. CD4 count is just suggestive of the answer in the question. So CD4 count is just suggestive. Okay, we'll look at a couple of images here. The first one is that very classical gomori methamine stain with that crushed ping pong ball appearance. And you can see bilateral infiltrates in both the lung fields of the patient. So that would be pneumocystis jirovecii. And the two-step question said like, what will you use in this particular patient? Then it is cotrimoxazole. He also said, what will you use for prevention? Then it is again cotrimoxazole. If you have allergy to sulfur drugs, you can use pentamidine nebulization. Pentamidine nebulization. Yes. In the second image, you can see alveoli. I mean, like the distorted alveoli, and then you can see these bacteria. These are like two dots which are present, two dots present, two dots present. And similarly, there is a consolidation also present here. So considering that there's a lung consolidation, there is also a patch in the X-ray, there is diplococcus that is present. So this would be pneumococcus. And every time we are dealing with any case of pneumococcus, then we'll have to decide the antibiotic on the basis of curve 65 score. So here, like the choice, I mean, we will decide whether to keep the patient in the hospital or whether to keep it at home on the basis of curve 65 score. The common antibiotics that would be given, assuming that the curve score of the patient is between 0 to 1, then the common antibiotics that we'll be using is amoxicillin, and along with that we'll be using azithromycin. If there is some risk factors given like previous hospitalization, then we can change over to augmentin, that is amoxiclav. If the score of the patient is between 1 to 2 or is even higher, then we can give respiratory fluoroquinolones to the patient intravenously. Or some questions where respiratory fluoroquinolones are not given, you will be using ceftriaxone, and along with that you can be using azithromycin, or it is ampicillin sulbactam with azithromycin as the antibiotic choice that would be used. So curve 65 score is never to decide the choice of antibiotics. Curve 65 is only to decide the need of hospitalization. But then based on the score values that are given in the question, we also make our decision to start antibiotics, like lots of time moxifloxacin as a respiratory fluoroquinolone that would be given to the patient. Yeah, we can do desensitization. It will take a very long time. And considering HIV, I mean, that would not be a very practical thing to do. Yeah, never a single antibiotic because of the resistance component. And then if you look at the last slide, this could be like a red bacilli against a blue background. And then we can see some, like it's a consolidation that has started as of now. It will evolve into a cavity in future. But then if we here, we will say that we are dealing with tuberculosis. And for any patient of tuberculosis, considering HIV is also given, you very well know that you first give ATT. And then after 2 weeks of ATT, that is when antiretroviral therapy in the patient would be started, not vice versa. That's because of the risk of iris in the patient. That iris is immune reconstitution inflammatory syndrome. If it occurs, we give steroids, but it should ideally be prevented by the use of antitubercular treatment. So at this particular moment, acute bacterial meningitis, बेटा ABM में तो कोई इशू ही नहीं है. वहाँ पे आपका जो आंसर है वो हमेशा क्या होगा, तो वो हमेशा होगा सेफ्ट्रैक्सन विद वैंकोमाइसिन. दो मैंने उसको बोलना था, बट क्योंकि आपने पॉइंट रेज किया तो आई से इट फॉर एक्यूट बैक्टीरियल मेनिंजाइटिस इट इज ऑलवेज सेफ्ट्रैक्सन विद वैंकोमाइसिन. अब वो क्या करेगा, वो यहाँ पे लिख देगा अल्कोहलिक या बोलेगा हार्ट ट्रांसप्लांट पेशेंट, तो इम्यूनिटी कम कर देगा. तो दिस आंसर इज वैलिड फॉर सेफ्ट्रैक्सन वैंकोमाइसिन इज अ स्टैंडर्ड आंसर फॉर एज मोर देन 3 months एंड अप टू 55 years ऑफ एज. बट आफ्टर 55 years तो लिस्टीरिया हो ही जाता है, तो वो 55 से कम पे दे देगा. क्या लिखेगा, अल्कोहलिक, या बोल देगा कि इम्यूनिटी ऑफ द पेशेंट इज लेस. तो अगर अल्कोहलिक है, इम्यूनिटी लेस है, स्टेरॉइड चल रहे हैं, डायलिसिस चल रहा है, इस टाइप की सिचुएशन देता है, तो आपको यहाँ पे एडिशनल कवरेज किस चीज़ का देना है, दैट इज एम्पिसिलिन. तो आप जो क्वेश्चन कर रहे हो ना ऐप में, उसमें सिर्फ क्या है, उसने अल्कोहलिक वर्ड ऐड कर दिया, जिसकी वजह से 3 एंटीबायोटिक हो जाता है, सेफ्ट्रैक्सन, वैंकोमाइसिन एंड एम्पिसिलिन टू द पेशेंट फॉर एक्यूट बैक्टीरियल मेनिंजाइटिस. अदरवाइज इट में ना कोई इशू बनने भी नहीं वाला. CD for cutoff for prophylaxis 200 only, na, and for like cryptococcus it is like more than 100. Okay ji. Yeah, till the CD4 count is more than 200 for at least more than 3 months, no? Second image, there is a consolidation and the bacteria, no? ग्राम स्टेन देख रहे हो तो पिंक बैक्टीरिया, पिंक जो दिख रहा है वो एल्वोलाई है जिनका इंफ्रास्ट्रक्चर डैमेज हो गया, और जो ब्लू डॉट है दैट इज द ग्राम पॉजिटिव कोकाई विच आर प्रेजेंट देयर इन two numbers, and then there's the left lone consolidation in the patient. Okay, अभी कर लेते हैं, प्लूरल एफ्यूजन भी कर लेंगे यहाँ पे. ATT ट्रीटमेंट फॉर टीबी मेनिंजाइटिस पूछ रहे हो कि रूटीन पूछ रहे हो. ATT तो 6 ही रहता है, बट अगर वो उसको एक्स्ट्रा पल्मरी है तभी तो 1 year का करेंगे ना. ओके जी. यार अपडेट्स के लिए ना मैं आपको एक 20 मिनट्स का वीडियो दे दूंगा, उसमें क्या है, 10 अपडेट है पूरे पूरे 25 26 के 20, है ना, तो 2 2 मिनट्स फॉर एवरीथिंग, दैट वुड बी लाइक मे बी 20 मिनट्स मैक्सिमम। तो अभी थ्योरी पढ़ लो यार, वो तो मतलब यू नेवर नो द फैक्ट ना। ओके जी, फाइन। चलो जी, अगले सवाल पे आते हैं। बहुत सारा डिस्कशन हो गया, मैंने बहुत ज़्यादा टॉकिंग कर दी इसके ऊपर में। वाई नॉट टू सस्पेक्ट न्यूमोसिस्टिस इन दिस, कौन से वाले में? न्यूमो इसमें, बिकॉज बेटा इसमें डल नोट लिखा है ना, यही तो बता रहा हूँ कि CD4 काउंट से सॉल्व नहीं करना है क्वेश्चन। आप ऑस्कल्टेटरी फाइंडिंग देखोगे ना, न्यूमोसिस्टिस ज्यूरोवेसी जो होता है उसमें तो ऑस्कल्टेटरी फाइंडिंग होती ही नहीं है, या अगर होती भी तो ओकेशनल क्रेपिटेशन होती है। सपोज अब मैं, आई गेट योर पॉइंट, जस्ट लेट मी एड्रेस दिस चैप, आई रियली विश कि मतलब ये गलती हम में से कोई भी ना करे कि ओकेशनल, अगर मैं ऐसे बोलता ना कि ओकेशनल क्रेप्ट्स आर प्रेजेंट इन बायलैटरल लंग फील्ड्स, या मैं बोलूँ लंग्स क्लियर है। Suppose the question said auscultatory finding of the patient, said occasional crepitations, or he said the bilateral lungs of the patient are clear. आप न्यूमोसिस से जीरो बेसी बोलो, कोई दिक्कत नहीं है, राइट? तो हमें तो ऑस्कल्टेटरी फाइंडिंग पे जाना है ना। आप अगर किसी को इन्फेक्शन वाले पार्ट में थोड़ा भी डाउट है, तो आपने करना क्या है कि मेन से, अभी टाइम है 1 हफ्ता एग्जाम में, इन्फेक्शन सुन लेना। तुमने माइक्रो में, मुझे पता है कि तुमने मैम का डेटा बड़ा अच्छे से सुना हुआ है ना, लेकिन अगर तुम्हें लग रहा है कि मतलब ओवरवेलमिंग हो रहा है, then just listen to the infections that I have spoken about. That would help you understand the questions relatively better. चलो, हाँ, ऑर्गेनिज्म का नाम, ओके, सो दिस वुड बी न्यूमोसिस्टिस जिरोवेसी। ओके जी, दिस वुड बी न्यूमोकोकस, एंड द एक्सट्रीम राइट साइड वुड बी माइकोबैक्टीरियम ट्यूबरकुलोसिस। मैंने 2 स्टेप किया, मैंने सीधा ट्रीटमेंट वाली बात कर ली जैसे वो एग्जामिनर करता है, बट ठीक है, वेल वेल टेकन पॉइंट्स। ओके जी, कमिंग टू द नेक्स्ट क्वेश्चन। A 42-year man is having this fever, purulent secretions, and worsening oxygenations 5 days after being placed on mechanical ventilation. तो वेंटिलेटर एसिड निमोनिया पे सवाल बना रहा है। बायलैटरल इन्फिल्ट्रेट्स बोल दिया उसने। ट्रेकियल एस्पिरेट शोज ग्राम नेगेटिव बैसिलाई with pink colonies with a fruity odor, oxidase positive, and what is the appropriate treatment for this patient? Okay, guys, I'll wait for your answers in this particular case. The case is that of VAP. We are having a patient who's having ventilator associated pneumonia. The key thing which is present in this question is that there is presence of pink colonies. भाई जो लोग इसको बी बोल रहे हैं और सूडोमोनास बोल रहे हैं, मुझे बताना सूडोमोनास में पिंक आती है कि ग्रीनिश ब्लू आती है? मतलब इतना भी अज्यूम नहीं करो ना कि भाई इस क्वेश्चन का आंसर यही होता है। डू यू गेट पिंक कॉलोनीज इन, इस सूडोमोनास की कॉलोनी पिंक होती है या सूडोमोनास की कॉलोनी ब्लूइश ग्रीन होती है? हाँ, तो ब्लूइश ग्रीन होती है ना, तो इसका आंसर तो हो ही नहीं सकता। सर, दिस इज अ रिपीट क्वेश्चन ऑफ द इनीसेट एग्जाम। द ऑर्गेनिज्म जिसकी पिंक कॉलोनीज होती हैं, इसको फिर से पढ़ना, तभी मैं बोल रहा हूँ कि आपको लग रहा होगा कि हाँ यार ये तो ना क्वेश्चन बड़ा स्ट्रेट फॉरवर्ड सा होता है। इनीसेट वालों का वो दिखाते ऐसे हैं कि बड़ा स्ट्रेट फॉरवर्ड सा है, और फिर वो क्वेश्चन में ट्विस्ट डाल देता। तो आप क्या करना, आप इन्फेक्शन वाला कंपोनेंट सुन लेना। दिस इज बर्कोल्डेरिया सेपेसिया, एंड बर्कोल्डेरिया सेपेसिया के फीचर्स तो पढ़ने ही पढ़ने हैं। सूडोमोनास तो सर अब नहीं पूछेगा ना आपसे, वो तो मतलब ऐसे नीट पीजी की बात करो तो मैं फिर भी मानता हूँ कि भाई ही माइट आस्क यू रिगार्डिंग सूडोमोनास, बट इफ इट कम्स टू this topic, then a ventilator associated pneumonia, what he will ask you is Burkholderia, or he can ask you about Acinetobacter। तो आज आपको जब भी टाइम लगे, आज ही बैक्टीरियोलॉजी से ये दोनों को अच्छे से कर लेना, both of these. The answer to this question, however, is obviously not Acinetobacter. I wrote that just to sensitize you to that these are the two questions that can be given to you. एंड फाइनली करेंगे क्या, तो ऑब्वियसली नाउ यू गाइस हैव डन अ कोर्स करेक्शन ब्यूटीफुली। राइट आंसर Burkholderia sepacia would be managed with cotrimoxazole, that is trimethoprim sulfomethoxazole. So 2 questions where in fact 3 questions where in the paper where subtran is given, cotrimoxazole is given. One is for a diarrhea in a AIDS positive patient. I'll not name the organism. The answer will come up in few minutes from now. I'll show you the slide. Second is right now Burkholderia sepacia, and first one is obviously that HIV positive patient with pneumocystis jirovecii infection. Okay, ji, fine. So 20th is sorted, please. 20th, doc, I spoke majority in English only. I mean, The point I'm trying to say is VAP is there and the organism is Burkholderia cepacia because it's written pink colonies, no? So pink colonies are not a feature that you are going to be seeing with Pseudomonas. That would be bluish green color. And that's why the answer will change in this case. Piperacillin tazobactam would not be used. Yes, you were right. Cryptosporidium, but then Cryptosporidium, the drug use is nitazoxanide. But you put up a question mark there, Cryptosporidium, then it is like nitazoxanide. And I'm doing justice to everybody, right? I'm talking English only and Hindi. Paper is in English only, so you need to give me flexibility to talk 80% in English only, and then 20% would be that English component. Coming back, for somebody who commented Cryptosporidium beta, what you need to check out is it is nitazoxanide, and only for that वो बड़े वाला होता है cystoisospora. That is where it is cotrimoxazole that would be used. Yeah, Burkholderia often has multi-drug resistance, so we might have to use colistin in the patient. Prognosis is bad. Question was, what is the most appropriate first-line treatment? So we start with the older generation drug in the patient. No, beta, not toxoplasma. Toxoplasma is pyramycin and pyrimethamine, not toxoplasma. It is pyramycin. It is like, or most of the time it is pyrimethamine and sulfadoxine that is used. SP that is used. In pregnancy, it is pyramycin. Otherwise, it is sulfa. It is like sulfomethoxazole with pyrimethamine that is used for cerebral toxoplasmosis. Okay, beta. 20th is sorted. We come to 21st for today. I have a patient who came with diarrhea, weight loss, arthralgia, and then a hyperpigmentation present. So considering that there is a malabsorption that is coming, like GIP मैंने I move that up because उससे क्या था mind सारा उसी में फंस जाता है. So I wanted to look at this question with a neutral sense, just zooming out a bit so that I can bring all the options into your like attention. Diarrhea, weight loss, arthralgia, hyperpigmentation. There's a systolic murmur that is also present. So cardiovascular भी डाल दिया भाई, and then the biopsy is shown. So you can see that lamina propria, that PAS positive macrophage is loaded with bacteria is present. And the moment you see that PAS positivity and the moment I say that there is like lamina propria, intracellular bacteria loaded inside in the macrophages, you know that you are dealing with Whipple's disease. Now, considering that you know it is Whipple's disease, you have to figure out the subsequent options which are there. So step one is to identify Whipple's. Yes, guys. Yeah, diastase resistant. Exactly. Whipple's can involve like that PAS positivity word, if it is given, will give credibility to my diagnosis, right? But I will not rely on that. That only. What I could pick up was in the lamina propria, they were like dark blue inclusions, dark purple inclusions present. That is how I picked up that there must be some infection present. Yes, the answer to this is option number A only. That is option number 1 is the correct one. I mean, obviously, this is not gluten allergy. We're not dealing with celiac sprue in a patient. And since we're not dealing with celiac sprue, then obviously dermatitis herpetiformis also goes out to the window. And enteropathy associated T cell lymphoma is the cause of death. In fact, this is itself a question. What is the cause of death in celiac sprue? Then the leading cause of death in celiac sprue patients happens to be EATL. Surprisingly, it's not adenocarcinoma. Normally in the bubble, we read about like adenocarcinoma, but here it is enteropathy associated, not visible. Okay, associated with EATL. That's the leading cause of death in celiac sprue. So B, C, and D, all options are related to like celiac sprue only. There's only one thing that makes sense, that it's culture negative endocarditis, which is why the answer to this question is option number 1. You guys can quickly comment on the treatment for Whipple's disease also. Just waiting for your answers. There are 2 antibiotics that would be given, one intravenously and one oral. So can you just type them as well? Yeah. First we give ceftriaxone for 2 weeks, and then subsequently we give cotrimoxazole to the patient. So ceftriaxone and cotrimoxazole are the drugs that would be used for these patients. Yep. It is IV and oral subsequently. The cotrimoxazole may be for 6 to 12 months. Okay, moving to the next one, we have this 45-year-old man. There's like fever, then there's a upper quadrant pain with abdominal distension and hepatomegaly, and there's a lot of free fluid that's coming up in the peritoneal cavity of the patient. And then he says like, what would be, he's not asking you the diagnosis, he's saying like, what would help you in confirming the diagnosis of this patient. Considering that there is a sudden onset right upper quadrant pain, hepatomegaly in the patient. Yes. and there is a sudden onset ascites in a patient, because there is sudden onset right onset pain, hepatomegaly, and then free fluid in a patient, all of these go in favor of Budd-Chiari syndrome in a patient, because he has himself written the word absent flow in the hepatic veins. Even if that was not given, the remaining clinical features were sufficient. In Budd-Chiari syndrome, in the early phase, you will be noticing that the SAG value will anyway be more than 1.1, and at the same time he might even ask you regarding the ascitic protein. In the early phase, the ascitic protein, because the pressure will be more, so protein will be able to come in the ascitic fluid, so it will be more than 2.5 gram. In one of the INI-CET questions, they had asked regarding early Budd-Chiari versus late Budd-Chiari. In late Budd-Chiari, what happens is that the SAG value still remains more than 1.1, but because there is fibrosis, now protein cannot come. And if protein cannot come, then the ascitic protein values in the patient will begin to become lesser. So just take care of that minor aberration which is present. That is ascitic protein value more than 2.5 or it is less than 2.5. For the early phase, it is more than 2.5, protein can come. Later part, the fibrosis part will prevent the protein from coming. Then, the answer to this question is option number C. And if SAG is less than 1.1, then we have to think in terms of TP and TB. I'll just write it here also, though I think all of you are aware of that. SAG less than 1.1 is for TB, TPN. T is for TB. P से होता है peritoneal carcinomatosis. That would be either stomach cancer or ovarian cancer. So we'll talk about like malignancy that is coming up. Peritoneal carcinomatosis. Then is pancreatitis, and then is nephrotic. Yes. So TPN as such, like it's unlikely that it will ever cause a heartburn or will contribute to any kind of issues. It is just that the left side of the table needs to be the right side of the table here, and the left in the actual discussion that I've done, that just needs to be taken care of. So answer to this is option number C. It was BCS Budd-Chiari that had to be picked up. Let's do the next one. We have this alcoholic. He came with extreme drowsiness and behavioral changes. One question alcoholic is always anticipated, and the guy is unconscious in the ER. So his wife is worried. Obviously, she says he's passing that, bile leak also present. Doc VTV, you have a good point there. Bile leak also. Okay. Then is alcoholic who came with this behavioral changes and is unconscious in the ER. The ultrasound in the patient is showing shrunken liver with portal hypertension. RBS is okay, not very low. So, I will give sugar, but not immediately. Sodium is low, probably because of less intake. Okay, so I think most guys are misjudging the question. A lot of guys have missed the fact that he's passing black color stool. That means he could be bleeding inside. Any alcoholic, if he's gonna be like having black color stool, that means the guy is having a coagulopathy. And the reason why he's having unconsciousness is because of encephalopathy. So this is not a question of Wernicke's encephalopathy, and thereby the initial aspect of lorazepam, thiamine, and all those things are not valid for this patient, sir. Sir, this is not a case of delirium tremens. Did the question say that the patient is having any tremors? Did the question ever mention mydriasis, sympathomimetic stimulation? No, he just said two things in a question. This is not a question. This is INI-CET question of the previous years. And the first thing is to evaluate that the chap is not having Wernicke's encephalopathy. That is step one. Then is like, what should we do for this particular patient? Portal hypertension, yeah, agreed in a person. Portal hypertension will cause bleeding varices in a patient. So I should be giving octreotide if there's a bleeding varices. Now, if the question mentioned upper GI bleeding, okay, but at this moment, what is happening is that there is a lower GI bleeding because blood is little bit, blood is, the blood is going down due to gravity and is coming out via the lower GI part. Actually, it is, melena is also upper GI bleed only. No? Melena is also an upper GI bleed. Now, why that is happening is because the guy is bleeding internally. So I need to give lactulose. Lactulose will take care of the hepatic encephalopathy, and fresh frozen plasma will take care of the coagulopathy patient in the patient. A close option is B. I agree to that. Like suppose this question said he had come with bleeding varices. I would have been happily answering this as octreotide, but considering the fact that NG tube se dete na, we give lactulose. All interventions in hepatic encephalopathy are done by NG tube ना. आप जब हॉस्पिटल में देखोगे तो पिलाते थोड़ी ना उसको, NG tube में ही तो डालते हैं उसको. रिफैक्सिमिन भी तो NG tube में डालते हैं. And for the encephalopathy, we give fresh frozen plasma. So lactulose with fresh frozen plasma. None of the patients of liver damage whom you are giving lactulose is going to be in a position to take anything by a bottle like this. All of them are going to be unconscious. अपनी दुनिया में होगा है ना, dream zone में, and we have to put a NG tube in these patients. Yeah, why not B? Beta, I've already explained, but I'll just do that again. No, octreotide is always given, is the drug of choice for bleeding esophageal varices. Now, I agreed that any patient who's having, okay, somebody said portal hypertension. Let me now explain. If HVPG is more than 5, that is portal hypertension. Na? When do you have a bleed, vomiting of blood more than 12? So octreotide फिर बाहर हो गया ना. Octreotide when do you use? When HVPG is more than 12. So for those of you who said, sir, if you are not sure about the diagnosis, sir, I'm sure about the diagnosis. Bleeding varices occur when HVPG is more than 12. If the question mentioned that value, I would have gladly answered that as octreotide. Okay. Okay, fine. So I think in portal hypertension, portal hypertension में मुंह से खून की तो उल्टी होती है. It is an upper J bleeding तो only ना, तो melena means enteral J because of coagulopathy. When liver जब खराब हो जाता है तो INR का वैल्यू बढ़ जाता है. That INR has to be stabilized ना. That is the cause of enteral bleeding, and blood is a very good culture media, so it will worsen the encephalopathy in the patient. Yes, terlipressin, octreotide both are used for portal hypertension with HVPG values more than 12 in the patient. Okay. Behavioral changes by encephalopathy. Encephalopathy is the reason for the behavioral changes in a patient. Like वो मतलब अटपटी सी बातें करेगा ना, like when his wife is trying to wake him up, तो वो जाग नहीं रहा है, he's talking some non-coherent stuff. So that is the behavioral changes that she is noticing, and then he's not waking up at all. Okay, जी, fine. So we are sorted for 23. The answer is option number A. And no, there is no role of vitamin K. Absolutely no role of vitamin K for these patients. Hepatocytes are busted, man. That is fine. And octreotide is only given when there is mention of vomiting of blood. This guy is having internal GI bleeding. Why? Coagulopathy component. Okay. हाँ, गाली देगा बिल्कुल पेशेंट. Which of the following is seen in con syndrome? अल्कोहलिक तो क्या करेगा यार, लॉस ऑफ इनिबिशन होता है ना, तो वो यही तो करता है. मतलब इंडिया में वैसे भी ना बचपन से कस वर्ड सिखा देते हैं. तो चलो, लेट्स मूव ऑन. Okay, which of the following is seen in patients of con syndrome? Okay, normal sodium concentration very much present, because in con syndrome sodium will also be more and water will also be more. So there's a possibility that the concentration of sodium can be normal in the patient. So that is okay. A point is perfectly right. Pedal edema we don't see. Postal hypertension obviously we don't see. But because of the extra water in the body will cause stretching of the right atria. Extra water in the body will cause stretching of the right atria. This will cause release of atrial natriuretic factor, and atrial natriuretic factor will cause natriuresis. That natriuresis will explain why these patients would be having is the development of polyuria. So A and D, that is option number 3, is the correct one for this question. I think most guys gave the correct answer. Initially, maybe there were some errors of judgment that were present. But this is again a repeat from INI-CET only, that con syndrome, the sodium values can be normal. The reason is that they can be normal, they can be lesser also, right? They can be lesser also. No? That's why we say the word hypervolemic hyponatremia in these patients. So the water can be disproportionate as compared to the salt component. Yeah. So we are sorted for 24th, guys. I'll say this once again for those of you who missed it. Salt is more, water is of both will cancel. In fact, ulta bhi ho sakta hai. They can be hypervolemic hyponatremia present in a patient. But the bad news is there is more water in the body that's coming in. Concentration is mathematical expression. उसको पढ़ के मत सोचना कि सच्ची में सोडियम कम हो गया. No. In con syndrome, total body water and total body salt both are more. I have put 2 arrows and 1 arrow to say water is disproportionate to salt, but don't be under impression that salt in the body is less. Salt in the body is more. It is the concentration which is false value. वो तो maths की value है ना, mathematics coming into picture, which is why the manifestations are there. Yes. No, there would be no pedal edema that would be present in this patient. Pedal edema is a feature that is seen in secondary aldosteronism. Pedal edema is a feature that is seen in secondary aldosteronism. जैसे PIH की लेडी है, तो उसमें तो हमेशा पीडल एडिमा से शुरू करते हैं ना, प्रेग्नेंट लेडी, पीडल एडिमा, एलिवेटेड ब्लड प्रेशर, बट कॉन्स डज नॉट हैव अ पीडल एडिमा। क्यों? तुम्हारे सामने नाइट्रोयूरेसिस से सॉल्ट लॉस हो जाता है, जितना सॉल्ट आ रहा है ना उतना निकलने की भी कोशिश कर रहा है, तो इस वजह से यू वुड नॉट बी हैविंग इज अ डेवलपमेंट ऑफ लाइक I mean the salt will tend to balance each other, and similarly the water will also be lost. Okay, so salt and water loss explains the fact that you don't have a pedal edema occurring, but you have a polyuria present. So we sorted. Okay जी, गॉर्डन एंड लिडल। ओके यार, चलो अब आपने बोला तो मैं इसके बाद में करवा देता हूँ, गॉर्डल और लिडल बस बहुत ही आसान है, राइट। सो बिफोर वी डू दैट, लेट्स डू द नेक्स्ट वन। Yes, what will be the findings on a liver biopsy in the patient who's having HbA1c of 12%? Yeah, I mean, liver biopsy of a patient with the HbA1c of 12% would always be, हाँ जी, the answer would be A, Mallory tank bodies would be seen in the patient. Yes. No, C नहीं है बेटा, वो किडनी में होता है. Kimmelstein Wilson change is seen in the kidney. Armani Epstein change is glycogen deposition. Armani Epstein change would be glycogen deposition in the proximal converted tubule. Kimmelstein Wilson is the characteristic manifestation in the kidney of the patient. So it would be Mallory Highline bodies for this one. Okay, quick looks at Gordon versus Liddell. In Liddell, there is a gain of function of the epithelial sodium channel. It will be working more than normal. Whereas in Gordon syndrome, it is the sodium chloride co-transporter that will be working more than normal. The sodium chloride co-transporter is the same one that is working in the distal tubule, and the effects of Gordon will be opposite of that of Gitelman syndrome. So in these patients, the sodium chloride co-transporter is working more. So salt in the body will be more, right? And along with that, the chloride part in the body will also be more. Salt and water, and I mean sodium chloride co-transporter. So salt is more, the chloride in the body will also be more, and that expands the plasma volume, and therefore like I can say that hypertension will be a manifestation that is occurring. Now hypertension will occur on the right side also, but there's a fundamental difference that would be coming up with respect to Gordon syndrome in the patient from the perspective of electrolytes. Yes, it is totally opposite of Gitelman syndrome. Gitelman में क्या होता है कि ये इसका loss of function हो जाता है, यहाँ पे gain of function हो जाता है. So first is the hypertension component, but अब क्या होगा, यहाँ पे feedback system operate करेगा, and because of the feedback system, the aldosterone values in the body will become less, and because of the inhibition or the decrease in the aldosterone values. In fact, I should mention the word is decrease of aldosterone values. The aldosterone की value कम होने की वजह से potassium, remember sodium and potassium have an inverse relation whenever aldosterone comes in the picture. When aldosterone is more in the body, you would be having is more like if you have more aldosterone, there is less potassium. If there is less aldosterone, there is more potassium. So in these patients, what will happen is that the potassium values, I'll use a different color, the potassium in the body will begin to rise. So that's one of the main thing that would be happening, that Gordon syndrome, the potassium values will rise. The reason is aldosterone कम होना शुरू हो जाता है. Let me work out the Liddell before you. Liddell is like just an application of epithelial sodium channel. More salt and more water. So more salt and more water will explain the hypertension component, but now the difference will come that the patient will be having exaggerated loss of potassium and will be having excessive loss of hydrogen. So in this case, the question will mention manifestations identical to that of what you read with Conn syndrome, that is hypertension with hypokalemic alkalosis would be coming. और यहाँ पे क्या होना होगा कि यहाँ पे हाइड्रोजन बढ़ना शुरू हो जाएगा. भाई एल्डोस्ट्रॉन जो होता है वो जब बढ़ता है, एक चीज याद करना, अगर एल्डोस्ट्रॉन बढ़ता है तो सोडियम पोटेशियम का जो रिलेशन है वो ऑपोजिट चलता है. अभी तो मैं एल्डोस्ट्रॉन की बात भी नहीं कर रहा, मैं बोल रहा हूँ एपिथेलियल सोडियम चैनल ज्यादा काम कर रहा है. इट इज गेन ऑफ फंक्शन ऑफ एपिथेलियल सोडियम चैनल, सो इट विल जस्ट गेट मोर सॉल्ट एंड वाटर, दैट विल एक्सप्लेन हाइपरटेंशन. बदले में पोटेशियम और हाइड्रोजन निकल गया, सो इट्स गोना बी हाइपोकैलिमिक एल्कोलोसिस दैट इज कमिंग. सो द फीचर इन लिडल इज गोना बी हाइपरटेंशन विद हाइपोकैलिमिक एल्कोलोसिस. और इसको लॉजिक से कर लेना, मतलब निमोनिक में जाने की जरूरत नहीं है. एंड व्हेन इट कम्स टू गॉर्डन, तो आपको गॉर्डन रामसे के बारे में सोचने की जरूरत नहीं है कि भाई आप वो शेफ आया, वो शक्ल बना रहा है, वो कुछ कर रहा है, तो जो मतलब किसी भी गॉर्डन रामसे डांटेगा तो भाई उस गॉर्डन रामसे इतनी बेइज्जती करता है कि आपको भी शो देखते हुए गुस्सा आना शुरू हो जाता है. गुस्सा आएगा तो भाई सब कुछ बढ़ना शुरू हो गया, बीपी भी बढ़ गया, पोटेशियम भी बढ़ गया, हाइड्रोजन बढ़ गया. तो वन वे टू लर्न इज लाइक दिस, नो, गॉर्डन रामसे एंड हिज फेस इज ऑल रेड, ही इज होल्डिंग द कैंडिडेट एंड यू आर आल्सो गेटिंग एंग्री कि कितनी बेइज्जती कर रहा है, इसको बोलने की तकनीक नहीं है. तो दैट इज वन one of the ways to work it out. But in my opinion, if you work out the data as I've highlighted, there would be relatively easier to identify. Yeah, exactly. Chris Souza, you have a point there. Loss of bicarbonate to maintain the electron neutrality, right? But I can put it a much more easier way. The much more easier way is aldosterone when it is less than salt. Obviously, we are trying to lose salt to counterbalance the increased sodium in the body, but the potassium part would be relatively higher in the patient. Yeah, renin levels in both of them would be suppressed, man. Renin would be lesser in both of them. Right? Hypertension or renin, so renin values will begin to reduce in the patient. Okay, ji. Fine, guys. So I think that was the difference between the Gordon and the Liddell part that was put up in the chat by somebody. Answer 25 is option number A. We can go to 26 now. This is a man with type 2 diabetes who has come to the hospital with CKD with rapid breathing. He underwent a minor surgery and he was also fasting for prolonged periods. So as of now, the blood gases are a little disturbing. Bicarbonate is only 14, PCO2 is 29, pH is 7.24. So I'll just say pH is less, the PCO2 of the patient is also less, and bicarbonate is also less. So it is a metabolic acidosis. I hope you can also apply the Winter's formula in this particular case and calculate the expected PCO2 of the patient. This will not have any bearing on the answer in the question, but just a quick practice here. Expected PCO2 will be bicarbonate value plus 15. Whatever is the bicarbonate value, like bicarbonate is given to be 14. So if you add to this, the value will become exactly what you want. That is the actual PCO2. Expected or actual match kar rahe. This guy is actual PCO2 is 29, and the one that I've calculated at the moment is also, okay, I need to move back a bit. Yes, actual PCO2 and what I've calculated, the expected one are matching. So this means the compensation part is working. Anion gap is 16, which is little on the higher side. So the final answer is the guy is having a HAGMA, high anion gap metabolic acidosis, which is partially compensated. The final answer is HAGMA, high anion gap metabolic acidosis, partial compensation of metabolic acidosis, and then is obviously that sugar that is like not fitting the threshold of diabetic ketoacidosis. For diabetic ketoacidosis, the D component should be random blood sugar 250 से ऊपर होना चाहिए. The K component in the patient should be in the form of ketonomia or ketonuria. So that part is okay. Urine ketones are positive that are given. And for the acidosis component, the pH should be less than 7.3 or bicarbonate low. So that all parts are satisfied. But this is a case of euglycemic. Like this is a cause of euglycemic diabetic ketoacidosis that would be empagliflozin that would be given to the patient. So answer to this patient is option number B. That was well picked up by majority of people. Yep. Partial compensation कैसे? Okay. यार मैंने जो टेबल बनाया ना एक्चुअली में एबीजी के एनालिसिस का, आप उसको एक बार सुनोगे तो उसमें मैंने यही बात बोली है कि एक्सपेक्टेड और एक्चुअल पीसीओ2 जब मैच करते हैं ना तो हमें बताता है कि भाई दिस इज अ पार्शियल कॉम्पेंसेशन दैट इज हैपनिंग. अगर ये वैल्यूज मैच नहीं हो रहे होते तो फिर अलग अलग पॉसिबिलिटीज रहते, इट कैन बी मिक्स्ड डिसऑर्डर नॉट. एंड या पीएच इज नॉट नॉर्मल, राइट? पीएच इज नॉट नॉर्मल, तो पीएच नॉर्मल हो जाएगा तो देन वी विल से फुली कॉम्पेंसेटेड. pH is normal, then I'll say it is fully compensated. pH less है तभी तो बोल रहे हैं ना partial compensation that is happening thanks to the small breathing. अच्छा, I get the point. क्यों आप बोल रहे हो कि सर partial compensation क्यों है? आप ये कह रहे हो कि pH तो है नहीं नॉर्मल, तो फिर इसको पार्शियल कैसे बोल देंगे? भाई पार्शियल कॉम्पेंसेशन का मतलब ये नहीं होता है कि pH नॉर्मल हो गया. पार्शियल कॉम्पेंसेशन मतलब पता क्या है कि आदमी हाइपर वेंटिलेट कर रहा है वो स्मॉल ब्रीदिंग से, है ना? क्योंकि जब कार्बन डाइऑक्साइड निकलेगी बॉडी से तो इनडायरेक्टली प्रोटॉन्स मेटाबोलाइज होने शुरू हो जाएंगे. So small breathing is happening, PCO2 is less, that is why the answer here. Okay ji. I think we sorted for 26th, we go to 27 at the moment. This guy started on a drug which will obviously be allopurinol. Yep. Quick answers here. Yes, Javier, that's the point. Euglycemic diabetic ketoacidosis, the D part is not satisfied. That's why the answer is like this. Okay, guys, more people to comment for this one. Yeah, the guy is having Steven Johnson syndrome. He's asking you which is responsible for this. Yes, guys. Yes, waiting for more people to comment on this one, guys. It is always a black box, no? It is always a black box for Steven Johnson. And how do we differentiate between Steven Johnson and toxic epidermal necrolysis? I mean, how do we differentiate between the two? Is based on the body surface area, na? It is based on body surface area, guys. Like if it is less than 10% or if it is more than 30%, and if it is gonna be an overlap between the two. If it is overlap, then we will say SGS, toxic epidermal necrolysis overlap syndrome in a patient. So hemorrhagic crusting of lips is what is highlighted at the moment. And like in this particular case, guys, the answer is option number C, that is HLA B5801. A lot of people have answered B51, but it is actually B5801. So I think there must be some words that would be missing in a question, because most of the time, like whenever I say severe cutaneous adverse reactions, we call them SCAR. I mean, what is happening in the patient is the SCAR, severe cutaneous adverse reactions with allopurinol. I think most of the time, the what I could pick up in the chat was the answer going up as option number C, option number B. But I think that small number aberration could have happened there. So the correct answer for the current question is, and it's very common in Southeast Asian population. Yeah, abacavir is option number B. Exactly. Yes. So we are sorted for 27th. I mean, if that happened due to some mnemonic का error, तो उसको ठीक कर लेना. मतलब अगर आप mnemonic से याद करते हो तो. Exactly. I think lot of guys have tried to use some mnemonic there, which somehow went wrong. So that is the reason why. I mean, somebody sent me this question also and saying कि सर ये तो mnemonic के हिसाब से शायद B बनता है और आपने C बोला है. तो I said यार textbook data तो यही बोलता है. So 27th is sorted, guys. Do check out if you had any errors from your mnemonic from where you have learned this. Okay. Okay, fine. Guys, before I चलो इसको कर लेते हैं. I mean, you know that SLE would be a type 3 hypersensitivity reaction which is present. Must-have criteria for diagnosis of lupus will be antinuclear antibody. The most common body system, this was a May question, is the musculoskeletal involvement. The type of arthropathy can be like any large joint, but it would be non-erosive. Then is the most common type of anemia seen is normocytic normotype of anemia. Anemia of chronic disease. But if it says what type of anemia in SLE is taken as a diagnostic criteria, then it is autoimmune hemolytic anemia. Obvious to say that normocytic normochromic anemia cannot be taken as like a diagnostic criteria, because it can be seen in so many other medical conditions. The leading cause of death में थोड़ा सा issue रहता है, but what Harrison says is leading cause of death would be kidney involvement only, that is lupus nephritis. Then like in the first decade of diagnosis, okay, after a decade, okay, if it is after a decade, the answer will change. In the first decade of diagnosis versus after a decade of diagnosis, the question will change. Initially it would be lupus nephritis only, but in the later years, like maybe 10 years 20 years down the line, it would be enhanced cardiovascular mortality, that is accelerated atherosclerosis in a patient. So I'm sure most of the time in the apps they'll be giving age like 40 45 because of the higher age group. Then we have to say as lupus in the patient. Then drug-induced lupus will be always having a female to male ratio of like 1:1. Normally, like SLE has a 6:1 ratio, but this would be 1:1 ratio that would be present. And the drugs responsible would be like hydralazine. Then the drugs responsible would be isoniazid, procainamide, and then is methyl dopa. Yes, it would be hydralazine, isoniazid, procainamide. The procainamide, the same molecule that we use in procainamide, the same molecule that we use in management of Wolff Parkinson White syndrome. In case there's a tachycardia component, then is methyl dopaminocycline and quinidine as well. So HIP M are like MQ are like the drugs which are responsible. And let's attempt a couple of questions on the same as well. The pattern is what I think the pathologist would have also spoken about. So like the images I don't need to describe. Antibodies I have already spoken about. And the male to female ratio is 1:1 with respect to DLE, that is discoid lupus erythematosus. Then is this image where you can see very characteristic lesion on the face, and he also mentioned that it is worsening after like going in the sunlight and after hot drinks. Options are in front of you. You can do a quick comment here. Yep, this would be yeah, because it is mentioning hot drinks, it is mentioning flushing. Basically, it is mentioning flushing in the patient. And considering that acne form lesions are also given in the question, so we will give it as acne rosacea as the answer to question number 29th at the moment. Yes. Moving to the 30th one. This is a woman who presents with proximal muscle weakness and difficulty in climbing stairs for previous 3 months. And then there's like skin tightening over the fingers with the Raynaud phenomenon, and there's sclerodactyly. So that word is like easy to identify. Heliotrope rash is also present there. 28th. Uh, yeah. This would be no. Yeah, drug-induced lupus. Yes. 28th is C. Tile. That is drug-induced lupus, not discoid lupus erythematosus. Point taken. Yes, guys. Coming to the 30th one. Yep. If you look at the data, like there's a sclerodactyly component, there is a polymyositis component present. So this is scleroderma and a polymyositis overlap syndrome. एंटी सिंथेसिस सिंड्रोम जो लोग बोल रहे हैं सर, उसमें तो फिर मैकेनिक्स हैंड्स होना चाहिए ना. एंटी सिंथेसिस सिंड्रोम में तो क्लासिकल मैनिफेस्टेशंस में एंटी टीआरएनए एंटीबॉडीज and then mechanics hand is a description should be given in the question. Here it is scleroderma and there's a progressive muscle weakness that is present in a patient. So there's an overlap that is present. Guys, this should have been a spot diagnosis. I think बीच में थोड़ा कई लोगों ने मिस मारा है. But yeah, most people were able to get this one right. Great. Shubhi and everybody else, they were like pretty particular about this one. Okay, so the correct answer for this is option number D. Then one in rheumat that they always ask in INI-CET is the Behçet's disease. Behçet's would be having that yeah, exactly mild, because it is written a mild heliotrope rash over the eyelids of the patient. So agreed, like there could be overlap of features of even dermatomyositis in the patient, but this would be a combination of like overlap syndrome, SCLPM. Okay. Then Behçet's is what they always ask, and for Behçet's I just want to highlight that males में ना there would be presence of scrotal ulcers. In males there would always be presence of scrotal ulcers, जबकि females में तो obviously vulva पे ulcers होते हैं, but male भी scrotal ulcer के बारे में हमेशा वो mention करता है, which is peculiar because normally we pick up like ulcers on the genitals of a patient. So like I put up a question to you guys at this moment. This would be the last one for today. Which of the following is correct about Behçet's disease? Yes, guys. The diagnostic manifestations are given. Pathology phenomenon is very much there. The disease will be involving the veins also. So incidence of deep vein thrombosis will also be there. So I'm waiting for your answers at the moment. Scrotal sac will be, ulcer will be there. Yeah. Sir, all will be present in the patient. ना pyoderma gangrenosum सब में pyoderma gangrenosum ulcerative colitis और Crohn's के साथ तो पढ़ते ही हैं. Ulcerative तो पढ़ते ही हैं, but we read it with rheumatoid arthritis, we read it with Behçet's disease also, and Behçet's will be having involvement of like large blood vessels. It will also have involvement of the veins, that is like deep vein thrombosis also present. It is all of these manifestations that would be present. The answer for this would be option number D. In INI-CET, that is the only issue that happens, that whenever we are doing some data, it is like, you know, combination of multiple facts. We have to like ensure that we are able to get to the most appropriate answer in the patient. So as of now, guys, that would be a quick burst of 30 questions that I wanted to discuss with you. Couple of theory parts in between were also discussed here. So mixed connective tissue disorder, mixed connective tissue disorder में डॉक्टर देयर वुड बी मेंशन ऑफ लाइक SLE वाले फीचर्स ना, और उसमें मैंने हैक भी बताया हुआ है कि SLE scleroderma, and then there could be mention of rheumatoid arthritis manifestations, and the best way to go about it is that antibody, U1 RNP antibody, that is ribonucleoprotein. And for overlap syndrome, it is the scleroderma and the polymyositis combination alone that would be present in a patient. So we can differentiate between these guys, and was like I thought it will be a very fast discussion, maybe 1.5 hour, but still it took me like, you know, to take up doubts in between. If I would have done a passive talking one way, then it also becomes too boring to listen, because then in a routine video class also, like you have those video lectures, it's only a one-way communication. So it was good to, okay, you really want me to talk about it, neuromyelitis optica? Okay, I'll do it. We'll do a quick neuromyelitis optica. Yeah, theory. So let's do it. I just skipped out of mind. Fine. I have it. Neuromyelitis optica. Let's do that. NMO. Here the antibodies against aquaporin 4. Na? Let's do that quickly. So neuromyelitis optica is formerly called as Davick's disease. And the highlight of this question will be, it will always begin by saying bilateral optic neuritis in like multiple sclerosis where it will be unilateral optic neuritis. See, multiple sclerosis, they will ask you mainly the pharmacology of the drugs. But for neuromyelitis optica, they will ask you the diagnostic criteria, that is antibodies against aquaporin 4. And the highlight is the spinal cord is involved. So he will always use the word LETM, longitudinally extensive transverse myelitis. Just hear me out for 2-3 minutes more and we are just going to do it. That is LATM, longitudinally extensive transverse myelitis. Now, in the diagnostic criteria, the core clinical features, that is what he says. The core clinical features is what he said, and this was like a INI-CET question जहाँ पे उसने multiple को select कराया. तो आपको ABCD सिर्फ तैयार करना है. एरिया पोस्ट्रीमा सिंड्रोम. हमें नॉर्मल क्या होता है कि वी रीड अबाउट ऑप्टिक न्यूराइटिस, वी रीड अबाउट स्पाइनल कॉर्ड इन्वॉल्वमेंट, सो वी अंडरस्टैंड कि भाई देयर वुड बी स्पास्टिक पैरालिसिस ऑफ लेग्स, देयर वुड बी ब्लैडर एंड बवल इन्वॉल्वमेंट, इट वुड बी अ फीमेल पेशेंट एंड वी थिंक इट इज सॉर्टेड. वो क्या करता है, उसमें डाल देता है इंट्रैक्टेबल वॉमिटिंग हिकअप्स विद एरिया पोस्ट्रीमा, ब्रेन स्टेम सिंड्रोम. तो सरप्राइज नहीं होना दैट ही माइट मेंशन अ क्रैनियलर पैल्सी ऑफ वन साइड and he might mention is a contralateral like hemiplegia. So midbrain stroke ka feature can be given in the question as well, and that is the confounding factor, because on one hand I was saying optic neuritis, spinal cord involvement, now suddenly there's a cranial palsy that is coming in. Then is the cord involvement, which is obviously the core feature, longitudinally extensive, early bladder involvement would be given. And then he will talk about diencephalic syndrome, unexplained weight loss and hypersomnolence. That is because of the hypothalamus getting involved and the optic. देखो ये जो D और E है ना, इसमें किसी को चक्कर नहीं पड़ेगा, C और E में चक्कर नहीं पड़ता. But it is like the A, B and the D part which is to be remembered. And in the brain there are cloud-like lesions. जैसे multiple sclerosis में तो हम पढ़ते हैं ना finger-like projections. In multiple sclerosis, we read about Dawson fingers, we read about black holes in the brain, and we read about periventricular lesions that are present. Here it is like cloud-like lesions that are present in the brain of the patient. And like for this particular condition, beta interferon का भी आंसर नहीं करना. Beta interferon can be used in multiple sclerosis, but never for these patients. Acute episode is obviously steroids, but beta interferon is never to be used for management of these particular patients. Yeah, periependymal cloud-like lesions would be present, but it is the A, B, and the D components which are to be remembered. And then for maintenance, we use rituximab and we use IV steroids for the patient. So as such, I can say that neuromyelitis, English में छुपा है, neuromyelitis optica, spinal cord involvement, optic nerve involvement. It is just the A's and the B and then the D components that I mentioned, area postrema, brainstem and diencephalic, which I just wanted to bring to your attention. So with this, guys, I think we are sorted for today. Thank you so much for your patience and joining in. And yep. So best wishes, guys, and take care for your preparation. I mean, keep reading facts and keep doing theory part. Practice as much questions as you can. Like we did a quick burst here. I mean, that was that question answer game. हमने जो question answer game खेला. That is what you need to do, and do it with like a bit of smile on the face, less frowning. That tends to like increase the positivity, and enjoy the process. These days will never come back, and one day you will be saying to your juniors कि हाँ यार कुछ नहीं होता ये सब है ना. It's just a part and parcel of life. So thank you, guys. Take care. God bless you. Bye bye. Sure. Take care. Bye bye. God bless you.